So can he start now? I think it's time.
Yeah, you can start.
Please start.
Okay. Good morning to respected staffs in the panel. Today is my e-paper presentation. My title of my presentation is Study of Perfusion Pressure in Primary Open-Angle Glaucoma. Coming to the introduction, primary open-angle glaucoma is a common form of glaucoma which is characterized by chronic progressive optic neuropathy, which is caused by a group of ocular conditions, which leads to characterized by the presence of glaucomatous optic disc changes or various visual acuities regardless of the intraocular pressure. Patients with open-angle glaucoma had either open or normal and appearing anterior chamber and had no secondary causes, and represents approximately 60 to 70% of the patients of all the cases. Besides the mechanical effect of raised intraocular pressure on the optic nerve, several risk factors such as systemic hypertension, atherosclerosis, vasospasms has been implicated as a potential factors capable of increasing the risk of open-angle glaucoma. Vascular hypothesis of open-angle glaucoma states that low blood pressure relative to intraocular pressure can lead to a low mean ocular perfusion pressure, thus impairing the perfusion of the optic nerve head that results in a glaucomatous cupping and visual field loss. Systemic hypertension is considered as one of the risk factors which can have a direct damage to the small vessels of the optic disc and may increase the risk of glaucoma. My study is regarding the ocular perfusion pressure, which is defined as the difference between the blood pressure, that is the mean arterial pressure, and the intraocular pressure. The mean ocular perfusion pressure is calculated as 2/3 of systemic mean arterial pressure minus the intraocular pressure. Multiplying mean arterial pressure by 2/3 here accounts for the characteristic pressure difference between the brachial and ophthalmic artery in a patient in upright position. Aim of the study is to study the relationship between mean ocular perfusion pressure and primary open-angle glaucoma in patients of primary open-angle glaucoma with and without hypertension. Coming to the methodology, the study design is a cross-sectional study. Study setting was run in Department of Ophthalmology in Justice K.S. Sector Charitable Hospital. Study period was between April 2021 to October 2021, and sample size required was 24. Coming to the inclusion criteria, patients who are diagnosed with primary open-angle glaucoma were included in the study. Exclusion criteria, patients who are diagnosed with systemic hypertension due to secondary causes like endocrine, kidney disease, and steroid-induced were excluded. Secondary glaucoma, angle closure glaucoma, patients with previous intraocular surgeries related to trauma, retinal detachment, complicated cataract surgeries, macular degeneration, maculopathy were excluded. Congenital ocular pathologies like glaucoma were excluded from the study. Severe associated comorbidities in the form of renal failure, congestive heart failure, sleep apnea, autoimmune disease with biological therapy was also excluded from the study. Patients who were also not willing for the study were excluded. Cross-sectional study on 24 patients, 12 from each group of hypertensive and non-hypertensive. They underwent a complete ophthalmological evaluation, including mischaracterized visual acuity, anti-segment evaluation, gonioscopy, Humphreys wheel analyzer, perimetry 24-2, fundus examination using 78D or 90D lens, intraocular pressure measurement using Goldman applanation tonometry, and blood pressure estimation in supine position, and mean arterial pressure, which was calculated by a measure of diastolic blood pressure, 1/3 of systolic blood pressure minus diastolic, and mean ocular perfusion pressure as 2/3 of mean arterial pressure minus intraocular pressure. Coming to the results, totally 24 patients were included in the study, out of which 11 patients where 10 patients were males and 14 patients were females, out of which 58.3 for females and 41.7 for males. Coming to the hypertensive group, 12 patients with hypertension and 12 patients without hypertension were included in the study. Mean age of this patients with hypertension was 60.6%, mean was 60.6, whereas in case of non-hypertensive group, it was 60.1. This is the chart showing the mean ocular perfusion pressure between the left and the right eye in hypertensive patients. In hypertensive patients, left eye, there was a mean of 44.61 compared with mean in the non-hypertensive patient, which was 36.92. And the mean ocular perfusion pressure in the right eye of hypertensive patients was 44.17, and non-hypertensive patients, it was 36.06. Coming to this statistical analysis was done using unpaired t-test. Where in the mean ocular perfusion pressure in the left eye, in hypertensive groups, it shows a statistical significance of 0.041. In cases of non-hypertensive groups, that is equal variance not assumed, it was 0.045, which is considered statistically significant. In cases of right eye with hypertensive group, there was a statistical significant data of 0.036 in the left eye, in the right eye, and also in non-hypertensive groups, it showed a statistical significant data of 0.04. Thus, assume that mean ocular perfusion pressure in both hypertensive and non-hypertensive group, they have a predominant significance. Coming to the discussion, ocular perfusion pressure is considered as a factor which has a role in glaucomatous disc damage. Based on this study, 8 out of 12 patients in hypertensive groups and 9 out of 12 patients in normotensive group, they had a low mean ocular perfusion pressure of less than 40 and were at a higher risk of primary open angle glaucoma and were more prone for further progression of the glaucomatous disc changes. A study which was done by Liang et al. Showed that there is a low mean ocular perfusion pressure in patients with primary open angle glaucoma less than 40, which was similar to our study. This was a study which was done between patients with primary open angle glaucoma and primary open angle glaucoma suspects, which showed that there was a lower mean ocular perfusion pressure throughout the course in primary open angle glaucoma compared with suspects. A similar study which was done by Topias et al. It shows that there was like a risk in glaucoma progression, which was similar to our study, but they have taken systolic and diastolic perfusion pressure, which was considered as a main parameters, where we consider mean ocular perfusion as a main parameter. And then in the study, they showed that diastolic had a clinical significance. There was a study which was done, which was a 9-year-old follow-up study, which was done in Barbados, which suggests that low mean ocular perfusion pressure of less than 40 has increased risk of developing open angle glaucoma, which is similar to those, which is similar in our study, which shows this lower mean ocular perfusion pressure of less than 40 has highly significance. A study conducted by Memorizet et al. They considered like mean ocular perfusion pressure as less than 50 millimeters of mercury as low, but in our study we consider less than 40, as more than 50% of the patients had less than 40 as a mean ocular perfusion pressure, and they also showed there is a high risk of primary open angle glaucoma progression. In a study which was conducted in Beijing, showed that there was no association between ocular perfusion pressure and open angle glaucoma risk, where our study showed that there is a relative lower mean ocular perfusion pressure, which has a risk of developing open angle. There was a study which was conducted by Deb et al., which shows that there was no difference in the glaucoma status between patients with hypertension and non-hypertension. But in our study, there was an equal association which was noted between the patients in hypertensive group and normotensive group in developing primary open angle. Coming to the conclusion, lower mean ocular perfusion pressure has increased risk of developing primary open angle glaucoma and can be used as a tool for predicting any further glaucomatous disc damage. And these are the references which I have used for this study. Thank you.
Did you keep into consideration the antihypertensive medication?
Yeah, ma'am, I have kept it, and the patients who are like on antihypertensives has been taken into consideration in this study, ma'am. Patients who are
have you classified the drugs? Did you sort of classify what antihypertensive they, 1 or 2, or which category of no?
No, ma'am, we haven't classified based on that. The patients we are just selected based on hypertensive group based on the previous medical records, ma'am. We didn't classify the drugs which they have been using.
Okay, because that also could have an effect, right?
Yeah. Because calcium
you could have mentioned that, as a drawback of the study, probably.
Yeah, ma'am. Okay, ma'am. Sure.
Yeah. Okay.
Any anti-glaucoma drug which can increase the ocular perfusion pressure, you know?
The drugs can either the only method will be like by decreasing the IOP, we can like change the course of ocular perfusion pressure. So like patients can be started on like beta blockers can be useful, sir. Beta blockers and rest of the drugs, because the only method is like we have to either decrease either by normalizing the BP or decreasing the IOP is the only chance. So like calcium channel blockers can be contraindicated in this study because they have no effect on intraocular pressure. They maintain the intraocular pressure, so it can be like.
My question was, do you know any anti-glaucoma drug that can increase the ocular perfusion pressure? Any study the company says that it increases the ocular perfusion? Yeah, one of the company dorzolamide, they say.
Okay.
The company claims that there is an increase in the ocular perfusion pressure.
Okay.
I think the next step, can start, I think so.
Thank you, sir.
Who's the next person? Is 1520 there? 1520. 1066.
1520. I'm here.
Okay, can you start, please?
Yes, ma'am.
Yeah. The next person, please be ready. 1066 after this. We'll try and save time.
That is your phone, no? No? So you'll get to know if I come. If yours? Mine is there. Mine, yours is after mine, no?
Can I start?
Please start. Yeah, please start. What is the allotted time?
Yes, ma'am.
You're allotted how much time?
6 minutes, ma'am.
6 minutes. Okay,
Yeah.
fine.
So today I'll be presenting a study on a correlative study of central corneal thickness with intraocular pressure with optic disc changes and visual field defects in primary open angle glaucoma. Ma'am, are you able to hear me?
Yes, yes. Please
Yeah.
go ahead.
Start slide.
So glaucoma is a primary is an optic neuropathy characterized by the typical appearance of the optic nerve head and characteristic visual field defects. So it is a progressive condition and is the most common cause of irreversible blindness worldwide. So primary open angle glaucoma is a type of glaucoma defined as an open, normal appearing anterior chamber angle with the raised intraocular pressures. Nearly 90% of the glaucoma is undetected and the third leading cause of blindness and accounts for around 5.80% total blindness in India. So in most of the patients with glaucoma, the clinically recognizable disc changes precedes the detectable field losses around 25 to 30% when the retinal ganglion cells are damaged or lost. Then only the visual field defects are seen. So optic nerve head cupping is also used to predict the visual field loss. Extensive and
Your
focal
slides are
absence
not
is unusual.
moving. Abdul, your slides are not moving.
Now, ma'am?
No, and please put it on PowerPoint show. It's stuck on the first slide itself. Okay, no problem. You can continue like this.
Yeah. Now, ma'am? No.
It's not moving. It's not moving. It's still on the first slide here.
Now it is moving, ma'am?
No, not on our screen.
The man Whitney test used to compare the results between the catatonic and normal subjects, and unpaired t-test was used to compare
Now?
the inter-eye asymmetry
No.
of.
What I suggest is maybe you can, the next person can present, you come back, just sort out your issue. Okay? Yeah.
Normal cornea.
Do we have the next number ready? 1066.
Less than 5 diopters here and astigmatism of less than 3.
Yes, ma'am.
Yeah. Abdul, you need to stop sharing your screen. End your presentation.
Coming to results. So total of 68 subjects.
1066.
136
Share your screen and start your presentation.
Where 34 with bilateral normalized and 34 with bilateral keratoconus. The mean age of the keratoconus group was found to be 19 with +5 minus 5 years, and normal group was 23 plus.
I don't know from where there is some background sound.
Yes, ma'am. I think the
You have to unmute yourself, Sauparnika. You are muted.
Madam, I think somebody else from the cornea section is also presenting in the same room as Sauparnika. Please check.
Okay, ma'am. Now audible.
Yes, yes.
My study is on the safety and efficacy of ripacidine
You're not very audible. Other judges, can you hear her?
What is echo coming?
Yeah, so Aparnika, I think your audio has some issue.
I think somebody else is also logging in from the same room ID or something. Please check.
You're not audible, ma'am.
Yeah, she's also, her video is off. Aparnika,
And the next
872 is the next person ready. 872.
Can I present?
Yes.
You're 872,
Yes, ma'am.
but it says 1349. Okay, fine. You're logged in from another this thing. Okay, fine. Start.
Okay. Am I audible, ma'am?
Yeah, you're audible.
My screen is
Please
as
start.
well. Okay. Good morning. Today I'll be presenting a paper on a study on ocular complication of inhalational steroids. Objective being to know the study of effect of inhaled corticosteroids on intraocular pressure. Introduction being glaucoma is a group of disorder involving optic disc and visual field defect with or without raised in intraocular pressure. Raised intraocular pressure is one of the most common cause of optic disc atrophy, and glaucoma is one of the leading cause of irreversible blindness globally. Recent guidelines in management of respiratory condition advocate to the early use of oral and inhalational steroids. And inhalational steroids are responsible for raised in intraocular pressure from the normal. Topical steroid eye drops are responsible for raised in intraocular pressure and development of glaucoma, and this is genetically predisposed, and 5 to 6% of the patient develop marked raised in intraocular pressure more than 31 mmHg after 4 to 6 weeks of topical corticosteroid therapy. In steroid-induced glaucoma, patient is asymptomatic and may present with corneal edema, blurred vision, ciliary hyperemia, colored halos, pain when intraocular pressure is high. And the important factor in corticosteroid-induced ocular hypertension is the increase in resistance to aqueous humor outflow. This study aims to know the effect of inhalational steroids on intraocular pressure. Material and methods being, this was a prospective study done on 49 patients on inhalational corticosteroid termed as group 1 and 49 patients on not on inhalational steroid termed as group 2. Group 1 patients were on fluticasone 250 to 500 microgram, while inhaled budesonide 200 to 400 microgram and budesonide and seclumoside combination 300 and 600 microgram. Now, IOP and central corneal thickness was measured with applanation tonometry and pachymetry respectively. Intraocular pressure of eye was used for comparison and data was analyzed. Ophthalmic examination included best corrected visual acuity with Snellen's chart, near vision with Snellen's near vision chart. Slit lamp examination of anterior segment was performed. Intraocular pressure was measured by applanation tonometry and an average of 3 reading was taken. Central corneal thickness was measured using pachymetry.
You are not audible. 872. Akarshita, you're not audible.
No. It stopped in between.
Akarshita, what happened?
I think there are a lot of technical issues. We should call the technical person who's inside of the hall. Kindly listen to it. There's a lot of delay.
Yeah, okay, we'll move on with the next person. 1198. Is 1198 here? 1385? Yeah, 1385. Bhavya, would you like to?
Yes, ma'am.
Yeah.
Yes. So good morning. Today I'm going to present a case of eye syndrome presenting with secondary glaucoma and complicated cataract. So eye syndrome is a rare condition characterized by proliferation and structural abnormalities of the corneal endothelium, progressive obliteration of iris iridocorneal angle and iris anomalies. It's sporadic in presentation, usually unilateral, and typically presents more often in females between 20 and 50 years of age. It comprises a spectrum of 3 clinical entities: progressive essential iris atrophy, Cogan-Reese syndrome, and Chandler syndrome. And etiology is still not clear, but theories include the membrane formation, low-grade inflammation, and virus infection with herpes simplex. And glaucoma develops in approximately 50% of cases, and it's more severe in essential iris atrophy and Cogan-Reese syndrome. So history, a 36-year-old male presented complaints of diminution of vision in right eye since 6 months associated with pain and redness. There is no ocular complaints in the other eye and no history of ocular trauma or ocular surgeries in the past, and patient has no systemic comorbidities and family history is not significant. So ocular examination, right eye visual acuity, there's no perception of light, and conjunctiva is, there's a conjunctiva and circumciliary congestion. Cornea is hazy, there's microcystic edema and ruptured bullae, and anterior chamber is shallow. A pupil correctopia is present, dyschordia is present, and pseudopolychoria, and it's non-reactive to light. At iris, there's atrophic iris holes are present. Lens is cataractous, and 80 at the time of presentation is 40 mm of Hg. Gonioscopy couldn't be performed due to hazy media, and fundus couldn't be visualized, but T-scan showed thickened incomplete PVD attached with optic disc. The left eye anterior segment examination was within normal limits, and gonioscopy revealed angle open in all 4 quadrants. So anterior segment clinical photograph, you can see the conjunctival congestion, and the cornea is hazy. You can see ruptured bullae, and multiple atrophic iris holes can be seen, and lens is found to be cataractous. So specular microscopy of right eye couldn't be done because of hazy cornea, but left eye specular microscopy, it revealed polymegathism and pleomorphism, and the cornea was found to be thin. A CCT of 475 microns was found. Anterior segment OCT of right eye was done. It shows temporal corneal thinning due to stromal scarring, and corneal epithelial edema was present, and irregular thickness of cornea was seen. So the patient was diagnosed to have right eye syndrome with secondary glaucoma and complicated cataract. The patient was started on anti-glaucoma medication mainly for symptomatic relief and advised to follow up regularly. He was put on Iop Distribution, glycerol syrup was prescribed, and tablet acetazolamide was given, and he was asked to follow up after a week. And nil visual prognosis was explained to the patient. On follow-up after 1 week, the pressure was still found to be high. It was found to be 40 mm of mercury, and the other eye pressure was found to be 14 mm. So medical management is usually insufficient for control of IOP, and surgical intervention is often required in eye syndrome. Glaucoma drainage devices may be required, as routine trabeculectomy with or without mitomycin C is less likely to be successful, mainly because the endothelial membrane is said to grow over the ostium site and impair the drainage. Corneal component of eye syndrome, surgical management, it can be done by performing penetrating keratoplasty or endothelial keratoplasty. And the success of this keratoplasty depends mainly on the control of IOP, and this control of IOP is very hard to achieve. And definitive keratoprosthesis like Boston type 1 keratoprosthesis may be tried as an alternative in case of repeated failure of traditional keratoplasty. Conclusion, this case shows that secondary glaucoma seen in eye syndrome causes rapid loss of vision and shows poor response to medical management. So early surgical intervention may be required to control the IOP due to eye syndrome. Thank you.
What is the cause of IOP?
Ma'am?
What is the cause of IOP?
Ma'am, the IOP in eye syndrome, the endothelial membrane, it grows over the trabecular meshwork, and it initially causes open angle glaucoma, ma'am. But later on, the membrane constricts and it causes anterior synechiae, which are typically broad-based peripheral anterior synechiae, and this later on causes secondary angle closure glaucoma.
Yeah, why wasn't a surgical option given, considered right in the beginning? Any particular reason?
Ma'am, we were like, the media was very hazy. We were just trying to reduce the corneal edema and improve the this transparency in the media first, and reduce the symptomatic. Like, he had lots of pain, ma'am. So we wanted to control the pain first. Symptomatically, we wanted to manage before surgery.
Other side was absolutely normal?
Other eye was absolutely normal, ma'am.
So what about the laterality of this condition? Is it usually bilateral or usually unilateral?
It's usually unilateral, ma'am, but some literature says that subclinical disease may be present in the other eye also, like endothelial changes may be present, but it doesn't cause clinical manifestation as such in the other eye.
Yeah, all right. Anybody else wants to ask?
No, continue.
Okay, so we'll go to the next presenter then.
Excuse me, ma'am. I just had my presentation halfway cut through due to the network issues. When should I be present?
Yeah,
I'll continue present.
Yeah.
Yes,
Your number?
872, ma'am. Akarshita.
Okay, fine. You can continue.
Should I start it from the very beginning?
No, where you stopped, you continue from there.
Okay, ma'am. Thank you.
I think beginning methodology, I think you stopped.
Yes, ma'am. Methodology.
Yeah. You start from there.
Thank you. Is it visible?
Yeah, your screen is visible. If you can, go to slideshow.
Yes, ma'am. Okay, coming to methods and material and method. This was a prospective study done on 49 patients on inhalational steroid, considered as group 1, and 49 patients not on inhalational steroid as group 2. Group 1 patients were on inhaled fluticasone 250 to 500 microgram, inhaled budesonide 200 to 400 microgram, and budesonide and seclonoside combination of 300 to 600 microgram. Intraocular pressure and central corneal thickness was measured using applanation tonometry and pachymetry. Intraocular pressure of the right eye was used for comparison and data was analyzed. Ophthalmic evaluation included best corrected visual acuity with Snellen's chart and near vision with Snellen's near vision chart. Slit lamp examination of anterior segment was performed. Intraocular pressure was measured using applanation tonometry with average of 3 reading was taken. Central corneal thickness was measured using pachymetry. Dilated fundus examination included direct, indirect ophthalmoscopy and slit lamp biomicroscopy using 90D lens. Conioscopy and visual field testing was performed. If intraocular pressure was more than 21 mm mercury or discharges were present. Visual field changes were considered significant if Humphreys 30-2 glaucoma hemifield test was abnormal, plus one or the more of the following with arcuate or paracentral scotoma, nasal step or advanced glaucomatic field loss was found. Now, inclusion criteria included for cases as inhalational steroids for more than 12 weeks with patients age of more than 18 years and willing to give consent. Controls the inclusion criteria included willing to give informed consent and patient not on steroids. Exclusion criteria for the cases where patient who refused for the examination, pre-existing glaucoma, family history of glaucoma, patients on treatment with topical steroid eye drops, corneal disorder affecting the applanation tonometry, parenteral or oral steroid for more than 2 weeks in the past, and patients on who were diabetics. Control were the patients who were not giving consent and patients on inhaled steroids. Coming to result, the mean age in the group 1 and group 2 was 53 and 53.4 respectively, as shown in the graph. And the control population had 22 males and 51.1% of females, while the cases had population of 16 males and 33 females, where there was no significant difference between the sex and the age of the two group compared. The group 1 had an adjusted intraocular pressure of 14.83 mmHg, and the group 2 had a mean adjusted IOP intraocular pressure of 12.79 millimeter mercury, which was significant, which had a significant difference. And the central corneal thickness in the group 1 was 543.16 microns, which was higher when compared to that of group 2, that is 537.4 microns. Now coming to distribution of the patients on inhalational steroid, as you can see in the table here, the fluticasone group had the higher number of members, that is 38 people, where the budesonide had only 5 patients in it, and cyclonoside with budesonide only 6 patients were present. And as you can see in the table 2, the fluticasone and in the group 2, that is the patient not on inhaled steroid, the mean IOP was 14.63 and 14.47 with a p-value of 0.8, showing there was no significant difference in the right eye intraocular pressure between the two groups. Coming to discussion, this study titled Effect of Inhaled Steroids on Intraocular Pressure was conducted on 49 patients with group 1 on inhaled steroid and group 2 not on inhaled steroids. The mean age in the study by Schroff et al. Showed that 53.93 was with aging ranging from minimum of 18 years to maximum 89 years, with the median age in the study by Michel et al. Was 65 years with range of 49 to 97 years. In our study, the mean age was 53.93, with the lowest age of the study population was 24, with the highest age being 83. The cases and controls in our study were well matched for age and sex. The control population had 22 males and 27 females, while the cases had population of 16 males and 33 females, with no difference between the genders. Case reports by Opatowski et al. Reported increased intraocular pressure with inhaled and nasal steroid usage and recommended routine surveillance of intraocular pressure in patients using long-term inhaled steroids. Gabri et al. And Michel et al. Showed positive correlation between the raised intraocular pressure with increased dose of inhaled steroids and family history respectively. Data from ocular hypertension treatment studies has shown that ocular hypertensives have average estimated risk of 10% of developing glaucoma over 5 years. It's also been found that approximately 3% of the cases with ocular hypertension, especially those with family history of glaucoma or chronic use of steroids, the ocular hypertensive response may be irreversible. We found there is a significant difference in recorded intraocular pressure between the control patients and the patients on steroid, with those in steroid group having IOP on the higher range than that of the normal, but not significant enough to cause ocular hypertension or glaucoma. Hence, regular follow-up can aid the early detection and treatment, which may reduce the progression of glaucoma. In our study, 3 patients had ocular hypertension with IOP 21 millimeter mercury, and none were diagnosed as glaucoma. Though a positive correlation between the inhaled steroids and the development of glaucoma was found, it may be advisable to record the baseline intraocular pressure prior to the commencement of treatment and follow up the patients on inhaled corticosteroids 6 months in order to detect ocular hypertension and manage effectively. Coming to conclusion, patients using inhalational steroids are seen to have higher COP with higher intraocular pressure with respect to control and hence needs regular follow-up. Inhalational of fluticasone propionate was found to be safe among the steroids used. Limitation was the budesonide and cyclonoside steroid group of patients were smaller in number and I had no financial disclosure.
Yeah. So I have one question for you. Why did you exclude those with the family history of steroid?
Family history of steroid?
Yeah, that was one of your exclusion factors, right?
Family history of glaucoma and
not family history of steroids. I meant family history of glaucoma. Sorry.
Because familiarly there could be a discrepancy now. They would also have raised intraocular pressure as well, and optic disc changes present could actually act as a confounding factor for what is the patient presenting with.
No, because in fact, the way I would look at it, see, if you went through the literature, they said those with family history had a higher chance of developing family history of glaucoma, had a higher chance of developing raised intraocular pressure after the use of inhalational steroid. That's what it said, right? So by excluding such people from your study, I don't know, like maybe it would have been more useful to also include this and discuss this, perhaps.
We considered it as a confounding factor and we excluded it.
Okay. And did you do any OCT to rule out pre-perimetric glaucoma in those who had? That was not done.
That was not my criteria at all. I didn't consider OCT. It was only visual field and gonioscopy that we considered. OCT wasn't considered in my
Not
study.
done. Okay, fine. And how did you plan this study? In the sense, it's a prospective study, right?
Yes,
and do all patients receive standard doses like this? How did you go about
the
this?
thing is, I coordinated with the pulmonary medicine HOD ma'am and knowing what were the doses that was given. Earlier, I was mentioned the fluticasone, propionate, plain was given to the patient. It was not given in combination with anything. But as I started collecting, I've noticed that budesonide and seclonoside in budesonide patient were receiving, where the combination of the drugs that patient received. Hence,
but is it so standard as you have mentioned?
Yes, ma'am.
You mentioned a particular dose.
Once in our OPD, that is prescribed. The one that prescribed by the pulmonary medicine with only that doses have taken into consideration, and they've generally given it in that doses. And it has been short study, ma'am, 12 weeks. They give budesonide and seclonoside for almost 2 to 3 months. They don't give it in long term, but fluticasone is given long term with that standard doses.
Anybody else has questions to ask? You're 872, right?
Yes, ma'am. Akarshita.
Yeah.
Akarshita.
Yes.
So, what did you say about the study on the central corneal thickness?
Sorry, ma'am.
Central corneal thickness, you said something, right?
Yes, ma'am. Actually, what I told is the group 1, that was the cases on inhaled corticosteroid had higher central corneal thickness when compared to that of the controls. Actually, when the central corneal thickness is higher, there is an overestimation. But when we are comparing for the study, we have already used that adjusted intraocular pressure, like subtracted or added the central corneal thickness and then only use the intraocular pressure for comparison.
But was the difference statistically significant?
It was not statistically significant. There was a difference in, but not significant enough.
Okay.
What advice you have for physicians starting inhalation steroids?
Sorry, sir?
What advice you have for physicians who want to start inhalation steroids?
One, before starting inhalational steroid, let the patient have a routine ophthalmic evaluation, including intraocular pressure measurement, go a set of visual field testing. That's also, that is what I would have suggested.
That's
a routine ophthalmic with fundus evaluation.
That's not routinely done. Probably it's a good suggestion.
Just one set so that we can follow up on the later date and see over every 6 monthly or yearly.
Okay, right.
Who's the next person presenting? 1469. 1469 is here.
Yes, ma'am.
Yeah, if you're ready, then you can go
Yes, ma'am. Yes, ma'am. Good morning, everybody. Today I'll be presenting a paper. The title is Assessment of Diurnal Variation of Intraocular Pressure and Central Corneal Thickness in Eyes with Pseudo-Exfoliation. Introduction. Glaucoma is the second most common cause of blindness and the leading cause of irreversible blindness worldwide. Pseudo-exfoliation syndrome is an age-related systemic disorder characterized by deposition of gray and white material over many tissues. It is the most common recognizable reason of open-angle glaucoma all over the world. The possibility of developing glaucomatous optic neuropathy at comparable intraocular pressure levels is more in eyes with pseudo-exfoliation glaucoma than in other types of glaucoma. Corneal thickness is suggestive of the metabolic status of the glaucoma. It indicates the level of corneal hydration. Central corneal thickness is not routinely measured for glaucoma evaluation.
So this effect is seldom considered in ophthalmic OPDs. Several studies have revealed that eyes with pseudoexfoliation syndrome show thinner central corneal thickness in comparison with normal eyes, and thin corneas can now be considered as an important risk factor for glaucoma independent of intraocular pressure. The diurnal variation of intraocular pressure is well known, but it is not identified to what amount of changes in corneal properties make a difference in the amplitude of measured IOP. Evaluating the diurnal variation in central corneal thickness could also augment the early recognition of those patients who are at risk of developing glaucoma, as a difference in the central corneal thickness throughout the day would lead to similarly changed intraocular pressure. There is a greater variation of central corneal thickness in pseudoexfoliation syndrome eyes. It is wise to measure central corneal thickness along with intraocular pressure, always to avoid incorrect IOP interpretations in patients with pseudoexfoliation syndrome. The purpose of this study is to observe the association of diurnal intraocular pressure changes with central corneal thickness measured with Goldman applanation tonometer and anterior segment OCT, respectively, in eyes with pseudoexfoliation syndrome. The aims and objectives were to assess the diurnal variation of intraocular pressure and central corneal thickness in eyes with pseudoexfoliation, to look for linear relationship between the diurnal variation of central corneal thickness with intraocular pressure. Materials and methods. The study design was an observational study for 1 year and the sample size was 49. The inclusion criteria were patients with pseudoexfoliation. Exclusion was any history of ocular trauma or prior ocular surgery, any ocular inflammation or infection, any known cases of glaucoma, patient with corneal disease and severe dry eye, uncooperative individuals, and history of contact lens wearer. The total patients were included. The males were 28 and females were 21. The central corneal thickness was 524 in the morning microns, and the IOP was 20 plus minus 8.50 mm of Hg. So it was seen that the IOP and the central corneal thickness were more in the morning time than at the 2 p.m. and the 9 p.m. time. At 2 p.m. it was 522.63 plus minus 14.13 microns, and the IOP was 18.16 plus minus 7.41 mm of Hg. At night, that is at 9 p.m., the readings, the mean was seen was 520.94 plus minus 9.25 standard deviation, and the IOP was seen as 11.92 plus minus 6.53. This study suggests that diurnal variation of intraocular pressure is seen in eyes with pseudoexfoliation, and central corneal thickness was thinner with lower IOP in this patient. Thereby, masking the glaucomatous changes can be also, it can also mask the glaucomatous changes. In one study, that is Asrani et al. Suggested that the diurnal IOP range and the IOP range over multiple days were significant risk factors for progression of glaucoma. In this study, basically, they had seen this diurnal variation in the two settings. One was at the office and one was at the home. So in this, they had measured the IOP intraocular pressure in patients, and the risk factors were also considered for the increase in the IOP and the progression of glaucoma. In patients, in the study, Keel et al. Suggested that diurnal variation has an influence on the central corneal thickness in individuals with pseudoexfoliation without glaucoma and may have a confounding effect on the underestimation of the intraocular pressure. So the conclusion is that the patients diagnosed with pseudoexfoliation showed a diurnal variation of intraocular pressure and central corneal thickness. And what was seen was the greater the central corneal thickness, more IOP was seen in patients with pseudoexfoliation, and the lesser the central corneal thickness, lesser was the IOP seen.
Any literature regarding variation of corneal thickness with pseudoexfoliation?
Ma'am, hello, ma'am.
Any literature available regarding variation of corneal thickness with pseudoexfoliation?
Ma'am, this Keel et al. Study, in this study also they had, it was a similar study in which they had taken patients with pseudoexfoliation on slit lamp, whichever they could find the pseudoexfoliation patients. And they had done the similar study only in which they had measured for central corneal thickness and the intraocular pressure. So the thicker the central corneal thickness, more intraocular pressure was seen. But in patients with pseudoexfoliation, usually the central corneal thickness was seen to be little thinner than the normal individuals. Thereby, it can cause like lower IOP measurements can be seen. And hence, the glaucomatous changes can be masked in such patients.
How much increase did you consider significant here? Because even in diurnal variation between the two readings, 1.52 millimeters is not taken as significant, isn't it?
It was not actually statistically significant. Like we had done the similar, but it was not very much statistically significant.
Okay.
Was it clinically significant then?
Clinically, yes, ma'am. Whichever patients we had seen in our OPD, the known case, like whichever patients we had taken in as a pseudoexfoliation patient, in that definitely there were.
How much was it? The maximum and the minimum?
Sorry, ma'am.
How much difference did you find? How much of variation?
The central corneal thickness of the on the patients in the pseudoexfoliation. Yes. In the like around, ma'am, around 10 micrometer it was there.
Your number is?
Mine is 1469.
Okay, fine.
Thank you.
1484 to be ready.
Good morning. My study is a comparative study between the effect of topical brinzolamide brimonidine combination and brinzolamide brimonidine combination on corneal endothelium. Glaucoma represents a progressive optic neuropathy characterized by nerve fiber layer defects, which leads to characteristic optic disc changes and visual field effects. It has multifactorial etiology, with intraocular pressure being the only major modifiable risk factor. The mainstay of treatment involves lowering the IOP by medical and surgical management. Medical management consists of topical administration of various classes of anti-glaucoma medications. Monotherapy is often insufficient to achieve the optimal reduction of IOP. Combination of drugs is hence often required. In order to achieve ease of administration and reduction of side effects of preservatives of multiple drops, fixed dose combinations are used. Also, compliance is better with fixed therapy than individual multiple medications. In this study, the aim is to compare the variability of endothelial cell count and central corneal thickness following use of two fixed dose combinations by using specular microscopy in newly detected primary open-angle glaucoma subjects for a period of 12 months. This was a prospective interventional randomized control study, which was conducted during September 2019 to September 2021 at a tertiary ophthalmic center. The study included 50 patients with newly detected POAG, primary open-angle glaucoma patients. 25 eyes received a fixed-dose combination of brimonidine with timolol, and 25 others received a fixed-dose combination of brinzolamide and timolol. The patients underwent detailed ocular examination and glaucoma evaluation. The central corneal thickness and endothelial cell count and IOP were recorded. CCT and ECC were recorded in specular microscopy. Patients who already had underlying posterior segment pathologies and corneal pathologies and also secondary open-angle glaucomas were excluded. The variability of endothelial cell count and central corneal thickness were recorded and compared. The results were as follows. The study included 50 patients, 44% of them were female and 56% were males. Among the 50 subjects in group 1, the mean age was 57.4, and in group 2, the mean age group was 60. Now, the results were tabulated using independent t-test. The results implied that the baseline variables such as central corneal thickness and endothelial cell count were compared, and which did not reveal any statistically significant difference between group 1 and group 2 at baseline. However, when we compared the results at the end of 12 months, it showed that the central corneal thickness and endothelial cell count did not show any statistical significance. But however, the IOP recording at the mean IOP recording at the end of 12 months was significant. Also, we noticed that the endothelial cell count had reduced over a period of 1 year, but it was not statistically significant. The results at the end of 12 months were also correlated, which also showed that there was no difference between group 1 and group 2 at the end of 12 months. Discussion. Corneal endothelium evaluation is important in glaucomatous patients receiving anti-glaucoma treatment. In our subjects, topical beta blocker and alpha agonist combinations with a carbonic anhydrase inhibitor and alpha agonist combination were used. There was no significant complications on topical treatment. Also, there was no significant changes observed in the corneal thickness or in the endothelial cell density. It was, however, observed that there was a decrease in the endothelial cell count, but which was not significant. The IOP reduction between the two groups was comparable. A similar study was conducted by Fitrit P in 2011 in Turkey for a period of 1 month, which showed that the fixed dose combination of timolol and brimodine in 23 eyes, which also showed that it did not have any profound effect on both ECC and CCT. A similar study was conducted in Egypt in the year 2020 by Mohammed et al., which compared another fixed dose combination, dorzolamide timolol with brimodine timolol, which the results of this study are similar to what we have done. A clinical case study was conducted by Vishwanathan in 2012 in Australia, which studied the effect of different topical anti-glaucoma medications on CCT in primary open-angle glaucoma patients. This study had 187 glaucoma patients, which were compared with 100 eyes of age-matched untreated glaucoma subject. This study concluded that CCT was significantly reduced in those treated with prostaglandin or combination of prostaglandin beta blocker, carbonic anhydrase inhibitors, and alpha agonists. No significant reduction occurred in eyes treated with only beta blockers alone. However, this study is in disagreement with our results. The limitations of our study were, our study followed up patients only for 12 months, and also glaucoma medications are applied over a long term, and a longer duration of study would further confirm the results of this study. Hence, the results of this study are likely to be representative of a long-term IOP control achieved by this fixed dose combination. Conclusion, the fixed dose combination of brimodine timolol and brinzolamide brimodine had no significant increase in the CCT or decrease in the ECC after 1 year of therapy in POAG patients. The decrease in ECC, however, it could not be attributed because of the fixed dose combination, as decrease was not significant. IOP control between the two FDCs was comparable. These are my references. Thank you.
Was there any way you ensured that they use the drug properly? What method did you use? Not even...
they were instilled topically. The installation was topically.
No, I agree. But many times it happens that you prescribe, you do your duty. Was there any way in which you ensured that they followed what you told them?
Yes, ma'am. We did a serial follow-up, ma'am, over 12 months. Every 1 month, we were calling back the patients, and we had the contact number of the patients, and we were tracking them for a period of 1 year.
That you're tracking the follow-up, but at home you don't know what they did, how they have used the drops. So
we counseled the patients, ma'am. We had taken a few more patients were actually included in the study. The compliance in patients who had good compliance, only those were included in the study.
Yeah, so that has to be mentioned. Otherwise, it's very difficult to believe that you recruited X number of patients and all of them followed what you told for a period of 1 year.
Yes,
you know a population, right?
Yes.
So you have to mention that so many were not analyzed because of
the compliance
lack
issues.
of compliance. And you also should make a note of how you ensured that they took their drugs properly. That's to be done. Okay. Just a suggestion for when you do such studies.
Thank you. We'll include that in the study.
Okay. Well done.
Thank you.
Madam, shall we call 1066? She had an audio problem.
Yes, sir. Sure, sir.
Sauparnika 1066. If you can.
Yes, sir. Yes, sir.
Sauparnika, you can present.
Yes, sir. Good morning. My study is on the safety and efficacy of ripacidil, 0.4% in primary open-angle glaucoma and ocular hypertension. Introduction. Glaucoma, a multifactorial chronic progressive optic neuropathy characterized by a retinal ganglion cell death, is a major cause of irreversible blindness around the world. According to the estimate published in 2014, between 64 to 70 million in 2020 and to more than 111 million by 2040 being affected.
Maybe internet at your end is not fast.
Not audible, Sauparnika.
Check the internet connection now. Yeah, you're audible now.
Yeah.
Introduction.
No, don't repeat. Go to the continue.
Ripacidil had an acceptable and superior safety profile in the studies, which show significant reduction of IOP as well as a pleiotropic effect, consisting of neuroprotection and fibrosis action, thus increases the retinal ganglion cell survival. Capacitor systemic side effects is equal or superior to that of the prostaglandin analogs because the reported systemic adverse effects are being minimal and except for those allergic reactions. And most of the local adverse events are transient and mild, with the most common adverse drug reaction being the conjunctival hyperemia, blepharitis, and allergic conjunctivitis. Eye pain, punctal keratitis, eye irritation, foreign body sensation is also noted. Corneal disorders are being very rare. Objective: to evaluate the efficacy, that is a mean reduction of IOP from the baseline value, and the safety consists of both ocular and systemic adverse events of ripacidil 0.4% eye drop in patient with primary open-angle glaucoma and ocular hypertension. Materials and method. The source of data is from the patient attending the OPD at Bapuji Hospital, Davangere. The study design is a prospective open-label clinical trial. Study duration is for around 6 months, and all the patients were given an informed consent and have a compelled for the follow-up. Inclusion criteria: patient of either sex above the age of 40 years, the newly detected treatment naive patient with early primary open-angle glaucoma and ocular hypertension. IOP ranging between 22 to 30 mmHg on at least 2 occasions, 24 hours apart, with the open angles on gonioscopy. Exclusion criteria: patient with primary open-angle glaucoma or ocular hypertension having IOP more than 30 mmHg, or patient with primary angle closure glaucomas or the other secondary glaucomas, patient with previous history of intraocular surgeries, and patient not willing to participate in the study. A detailed history was taken from all the enrolled patients. They underwent a comprehensive glaucoma evaluation. Following the baseline evaluation, the patient were put on the ripacidil 0.4% morning and the night 7 a.m. and 7 p.m. Patient were demonstrated the correct method of eye drop installation and punctal occlusion techniques. All the patients followed up for a period of 3 months on the day of 14, 30 days, and 60 and 90 days. During each follow-up visit, the patient underwent comprehensive glaucoma evaluation. The efficacy of ripacidil hydrochloride eye drop was compared to a reduction of IOP from the baseline IOP at all the time point of follow-up. Any adverse events that consist of systemic and ocular complaints was noted during the follow-up. Result: 10 eyes of 6 patients with a mean age was between 55 to 65, where the mean baseline IOP was 24 mmHg. The post-treatment IOP reduced to a mean of 18.78 mmHg, approximately 20%, that is 5.2 mmHg reduction of IOP from the baseline. During the follow-up on the 14th day, the IOP was reduced only to 0.4 mmHg. By the end of 30 days, it was reduced to 6.75 mmHg. And 60 days, it was around 7 mmHg, and 90 days, it was 6.8 mmHg. Mild transient congestion is the most common ocular adverse event experienced by the patient. It used to last only for 10 to 15 minutes and resolved on its own. No patient experienced any systemic adverse effects. Out of 6 patients, 4 patients experienced transient congestion, and irritation was seen in 2 patients, and itching was seen in 1 person. Discussion: ripacidil has advanced to a phase 3 clinical trial in Japan and has been recently approved as a novel drug in the treatment of primary open-angle glaucoma and ocular hypertension. Studies which evaluated the efficacy of ripacidil as a monotherapy, IOP reduction around 8 mmHg, and the K115 study, the interim 3 patients showed the IOP reduction to 3.5 to 2.6 to 3.7 mmHg. And in our study, the IOP was reduced around a mean reduction of 5.22 mmHg. The ripacidil is also combined with the other anti-glaucoma medication, which showed a significant reduction of IOP in the treatment of other type of glaucomas. Conclusion: ripacidil 0.4% brings about a good IOP reduction with a mild transient adverse effects and having a superior safety profile, which is acceptable and may be considered in the prescription of patients with primary open-angle glaucoma and ocular hypertension.
So what about normal tension glaucoma? Does it have any role in that?
Yes, ma'am. There are patients, the other studies showed that there is a role of reduction of IOP in normal tension glaucoma also.
Okay. And is there any particular reason you didn't consider NTG? Because many times in clinical practice, we come across many patients who fall under the NTG category and not POAG. So any particular reason you decided not to include them in your study, NTGs? You included ocular hypertension and POAGs, right?
Yes, ma'am.
Yeah. So why did you leave out NTGs? You would have got useful information. So you can plan that next study. All right. That's all from me. Okay. If there are no more questions, then I think we'll go to the next presenter.
Okay, madam.
982, your slides are seen. Yeah, please begin.
Good morning, everyone. This is Dr. Krutika, a postgraduate student from JJ Medical College, Davangere. Today I'll be presenting a paper on effect of antihypertensive medications on ocular perfusion pressure. Coming to introduction, ocular perfusion pressure is the pressure available to drive blood through the intraocular vasculature. It is measured as a 2/3 of mean arterial BP minus intraocular pressure, where mean arterial BP is diastolic BP plus 1/3 of systolic minus diastolic BP. Systolic ocular perfusion pressure is measured as systolic BP minus intraocular pressure, whereas diastolic ocular perfusion pressure is measured as diastolic blood pressure minus intraocular pressure. Subjects with systolic ocular perfusion pressure of more than 130 millimeters of mercury had a higher risk of developing POAG than those with that between 111 and 120 millimeters of mercury, whereas subjects with diastolic ocular perfusion pressure of less than equal to 50 mmHg had a 2.2 times greater risk of developing POAG than those with between 61 and 70 mmHg. Subjects with mean ocular perfusion pressure less than equal to 40 millimeters of mercury had 2 times greater risk of developing POAG than those with mean ocular perfusion pressure between 41 and 50 mmHg. Relative risk for development of glaucoma was 2 for systolic ocular perfusion pressure, 2.1 for diastolic ocular perfusion pressure, and was 2.6 for mean ocular perfusion pressure. Antihypertensive drugs like beta blockers and alpha blockers were found to have a protective effect against glaucoma as told by various studies. Objectives of my study was to compare ocular perfusion pressure in hypertensive patients on treatment and normotensive subjects. Coming to methodology, this hospital-based cross-sectional observational study included a total of 110 subjects which were divided into 2 groups, Group A and Group B. Group A included 55 subjects who were primary hypertensives on treatment. Group B included 55 subjects again with who were normotensive subjects. Inclusion criteria. Patients aged more than 40 years of either sex with primary hypertension and normotensive subjects were included in our study. Exclusion criteria. Hypertension due to secondary causes like renal causes, endocrine and steroid usage were excluded from the study, and diabetics, thyroid disease, cardiovascular patients were also excluded. A detailed history about hypertension, including medications used, dosing, and duration was acquired. Comprehensive routine ophthalmic evaluation by glaucoma specialist was done. An average of 3 readings of intraocular pressure was measured 1 hour apart with Goldman applanation tonometer. Similarly, average blood pressure was measured 1 hour apart with sphygmomanometer. Parameters such as mean arterial BP, systolic, diastolic, and mean ocular perfusion pressures were calculated using above recorded average intraocular pressure and blood pressure. Results of our study are as below. In our study, the mean age group of the patients was 53.9 years with a standard deviation of 8 in Group A and 47.7 years with a standard deviation of 5.4 in Group B. In Group A, 56% were males and 44% were females, whereas in Group B, 49% were males and 51% were females. So this is a chart depicting the comparison of blood pressure, intraocular pressure, and ocular perfusion pressure between 2 groups. It is Group A and Group B. Here, as we can see the highlighted ones, mean arterial BP in Group A was found to be 101.2 millimeters of mercury, and in Group B it was 91.3 millimeters of mercury. On comparison of systolic ocular perfusion pressure among both the groups, systolic ocular perfusion pressure in Group A and was found to be higher than that in Group B, and it was also statistically significant as calculated by unpaid t-test. Similarly, diastolic and mean ocular perfusion pressure were also found to be higher in Group A than Group B, and also were highly significant, again calculated by unpaid t-test. Coming to the next table, which shows treatment-wise changes in ocular perfusion pressure. When we compare different various type of drugs used, various type of antihypertensive drugs used among both the groups, we could not find any much significance. But beta blocker was found to be on a little lower side. Coming to discussion. Ocular perfusion pressure reduces in both hypotension and hypertension, resulting in ischemic damage to retinal ganglion cells. In our study, we found that in group A with mean arterial BP of 101.2 millimeters of mercury, systolic, diastolic, and mean ocular perfusion is statistically higher than normotensive group with mean arterial BP of 91.3 millimeters of mercury, indicating that ocular perfusion pressure in eyes of controlled hypertensive subjects is within normal range and thus showing its importance in glaucomatous damage. This result was comparable with the study done by Anna Horwitz et al., which also told that antihypertensive have a protective effect in glaucoma. Correlation between different group of antihypertensives and its effect on intraocular pressure, ocular perfusion pressure showed no statistical significance. This might probably be due to a small sample size of my study, which was 55 subjects of primary hypertensive patients. Conclusion. The findings of a cross-sectional observational study suggest that a significant association exists between ocular perfusion pressure parameters in controlled hypertensive subjects versus normotensive subjects, with ocular perfusion pressure being higher in the former, that is hypertensives, on treatment than the latter, showing the effect of hypertension control on ocular perfusion pressure and thus on optic nerve head. Further, a longitudinal study constituting large sample size with diurnal recording of intraocular pressure and blood pressure should be considered to corroborate these findings of our study. Thank you.
So, Kritika, did you consider the duration of hypertension?
Yes, ma'am, but it was not specific, ma'am. It was taken from the range was from 1 month to 10 years, ma'am. So
yeah, because that could also have an effect, right?
Yes, ma'am.
So yeah,
hypertension.
Anybody else has any questions?
Okay, madam.
Okay, so we'll go to the next candidate.
Thank you.
That is 1339. 1339 is ready. Is there any issue? Otherwise, 1392 can. 1392.
Hello, ma'am. 1392. Can I present?
Yeah, please.
Okay, ma'am.
Go ahead.
Okay. The topic of my paper is a comparative study between the beta blocker and prostaglandin analog as a first-line drug in the treatment of primary open-angle glaucoma. Introduction. Glaucoma is chronic progressive optic neuropathy caused by a group of ocular conditions which lead to damage of optic nerve with visual loss since the disease is treatable and because the visual impairment is caused by glaucoma is irreversible, early detection is essential. Glaucoma is second most common cause of blindness in the world after cataract and most common cause of irreversible blindness. Prediction rate of bilateral blindness was 4.5 million due to POAG in 2010. Early diagnosis prevents progression and further loss of vision. 4 important means of diagnosis are IOP measurement, gonioscopy, fundus examination, and visual field changes. Treatment of glaucoma should be instituted as soon as the definitive diagnosis is made. Treatment modalities are medical, laser therapy, and surgical, but initial management is always medical. The inclusion criteria of my studies are patients above the age of 40, patients with IOP greater than 21 mmHg, without previous glaucoma treatment, optics with changes suggestive of glaucoma, asymmetric cupping between both the eye, visual field defects suggestive of glaucoma. The exclusion criteria of my studies were previously diagnosed and treated patients, pregnancy, patient on systemic medication like beta blockers, patient on systemic respiratory and cardiovascular comorbidities, angle closure glaucoma, secondary glaucomas, patient with previous complicated ocular surgery, and the patients who were not willing to participate in the study. The aim of the study is to study the effect of prostaglandin analog in comparison with beta blocker in lowering the intraocular pressure in patients with primary open-angle glaucoma. Objectives was to set a target pressure for POAG patient, to study the effect of travoprost 0.02 to 0.04% in lowering IOP in POAG patients, to study the effect of timolol 0.5% in lowering IOP in POAG patient, and to compare the efficacy of travoprost and timolol in IOP reduction for POAG patients. Materials and methods. The current study was prospective hospital-based study, which is an observational study conducted for the period of 8 months with the sample size of 50 patients attending outpatient department at Department of Ophthalmology and MC Raichur. Out of 50 sample size, 25 cases each were assigned to 2 groups For the ease of study, the patient in group 1 were treated with travoprost 0.04% at night. Patient in the group 2 were treated with timolol 0.5% twice daily with the dosage interval of 12 hours. Patients were followed up for at 3 visits, that is 4-week, 8-week, and 12-week. Anterior segment evaluation, gonioscopy, IOP measurement, visual acuity assessment, fundus examination with 90D was conducted at each visit. They were asked for any new deterioration of symptoms on each follow-up, and compliance was checked by checking the drug level in the bottles which were used by the patients. Coming to observation and result, the mean age of presentation was 55.38 years. The sex distribution, males were 28 and females were 22. The baseline IOP before starting the treatment in group 1 was 24.00 plus minus 3 mm of Hg. In group 2 was 25.86 plus minus 3 mm of Hg. The baseline CDR in the group 1 was 0.70 and in group 2 was 0.67. The average IOP reduction at the follow-up visit of 4th week, 8th week, and 12th week are as follows. In group 1, it was 20.5 mm Hg, and in group 2 was 21.2 mm Hg at 4th week. At 8th week, the group 1 showed a mean IOP reduction to 19.55 mm Hg, and group 2 showed mean IOP reduction to 20.76 mm Hg. At 12th week follow-up, the group 1 showed reduction to 16.00 mm Hg plus minus 1.5, and group 2 showed 17.60 mm Hg plus minus 1.5. The mean IOP reduction at the end of the 12th week in group 1 treated with travoprost analog 0.004% was 8 mm Hg. The mean IOP reduction at the end of 12th week with the group 2 treated with timolol 0.5% was 6.4 mm Hg. Conclusion: both prostaglandin analog and beta blockers are effective in reducing the intraocular pressure in primary open-angle glaucoma patients, but on comparison, prostaglandin analogs were found to be statistically superior to beta blocker in lowering the IOP in POAG patients. Discussion: in our study, prostaglandin analog were proven to be more effective than beta blocker, but the main drawback faced was the cost of the drug, which plays a major role in the rural developing population where the study was conducted. So in conclusion, per se Indian scenario is concerned, management of glaucoma with beta blocker as a single drug is more affordable to patients. In patients who require better control of target pressure, prostaglandin analog would be a better choice due to its greater efficacy. These are my references. Thank you.
Megha?
Yes, ma'am.
Yeah, I just want to know how come you decided to do this study? What was the novelty that made you do the study?
The study
Need
was
for the study.
Okay, ma'am. The study was mainly done for newly diagnosed patients, ma'am, to determine which drug has a better efficacy in reduction of IOP. So I want, since the mechanism, yeah, ma'am.
Yeah.
Since the mechanism of
was
both
there
the drugs
something
are
that was
different,
not known which you have addressed?
I just there are two different mechanisms, ma'am. The mechanism for IOP reduction in beta blockers is different, and prostaglandin analogs is different.
Yeah,
So I just wanted
right?
to compare that by which mechanism the efficient reduction of IOP can be achieved. So
Did you see any literature?
Yeah, ma'am. Similar studies were done at GMC Nanded by Salim Tamboli et al. And also in Uttar Pradesh University of Rokhand, it was done by Ibrahim et al.
Shweta madam, I think wanted to ask something.
Okay, ma'am.
In the same patient, how do you know which of them behaves?
Sorry, ma'am.
In the same patient, how do you know which of them works better? Because you have used two different drugs in two different patients.
Yeah, ma'am. All these patients were newly diagnosed, ma'am, and we have made two groups. Group A was treated with the beta blocker and group B with prostaglandin, and we have called them for follow-up at same duration after diagnosis, that is after 4th week of diagnosis, first visit, after 8th week first visit, and 12th week another third
The
visit.
patient in group B has behaved better with timolol. How do you take it for a group A patient?
Group A patient has shown.
Do you really think they behave uniformly in all patients, both prostaglandins and timolol? So it cannot be a criteria. Group A patient, we should do well with prostaglandin, or Group B should do well with timolol only.
Okay,
Isn't it?
Yeah, ma'am.
How did you decide which
Ma'am, the study was conducted for the period of 8 months, in which 75 patients were screened, but only 50 patients were taken for the study, which were fitting properly in the inclusion criteria. So random selection of sample size was done, ma'am.
That is the sample size of the patients, the total number of patients, but you have distributed into
okay.
groups, right? So which patient to go for beta blocker and which patient for prostaglandin? Is it like every consecutive, or there should be some method just to prevent the bias?
Ma'am, random selection was done and people were divided into 25 groups for group A and 25 people for group B. The patients with cardiovascular or respiratory disorders, they were not been put in group 2, wherein we are giving beta blockers.
Okay.
Yeah, ma'am, thank you.
Ma'am, this is 1339. Can I present now, ma'am? Can you hear me?
Yeah, you're okay. 1339.
Yeah, it was before I couldn't connect.
Okay, no issues, no issues.
Yeah.
You can start. Please share your screen and start.
Yes, ma'am. Can you see me? Can you see my screen, ma'am?
Yeah.
Yeah. Hello. Good morning, everyone. I'm Dr. Manogna. Today, I'm going to present my paper, which is titled Peekaboo, We Can't See You. My main aim is to discuss an interesting case that we have seen in the OPD and to ask for your inputs, actually. So the aim of the paper is to report an interesting case of refractory secondary glaucoma, secondary to occlusive vasculitis of probable viral etiology. So I'll present the case report. She's actually a 26-year-old female. She presented to us in April 2021 with history of light sensitivity in the right eye and right-sided headache since last 1.5 months. She has shown elsewhere 1 month back, and her IOP was told to be high, and she was started on tapering doses of loteprednol and brimonidine, which she is continued later on because she did not see any response. And she had no history of trauma, redness, or previous such episodes. There was no history of preceding febrile illness or any other systemic problems. She did not use steroids in any form before. She gave a brief history of recurrent painless oral ulcers between the age of 18 to 22, but they relieved with multivitamins. There was no history of genital ulcers and no significant family or travel history. So I'll go into the details of ocular examination. In the left eye, we found that everything was normal. She had a refractive error of around -3.75 sphere with a BCV of 6/6, and rest of all ocular examination was normal, including intraocular pressure of 17. So right eye is the eye we are taking into consideration right now. So I'll go into detail about right eye examination findings. Her best corrected visual acuity was 6/9 in the right eye with a spherical error of -4. Her color vision and ancillary grid was normal. Ocular movements were normal. Intraocular pressure checked with GAT was 35 mmHg. It was checked at morning 11 o'clock. Her cornea was clear. There were no KPs that we could see. An anterior chamber was quiet and was normal in depth. Iris was normal. There was no neovascularization. In the pupil, we have noted grade 2 RAPD. The lens was clear. On gonioscopy was done with a 4-mirror, indentation 4-mirror. It showed open angles. There was no NVA and there were no synechiae, no pigment clumps or no other changes. It's just normal angle, normal looking angle. The central corneal thickness was measured. It was 554 in the right eye and 562 in the left eye. So coming to the posterior segment examination, in the left eye, everything was normal. In the right eye, the media was clear. There was no AVF was quiet. The optic disc was 0.7 curve disc ratio with the inferior rim thin that was noted. The macula was normal. In the vessels, the posterior pole was normal, but we could see sclerosed arterioles from mid periphery in all the quadrants. The veins were normal in caliber and there were no crossing changes. The pars plana and the periphery was normal. This is the fundus photo of the right eye. You can see the normal posterior pole, but here you can make out the sclerosed arterioles starting from the mid periphery and the disc showing the inferior rim thin. This is the 360 degrees picture showing the sclerosed arterioles in all the quadrants. Only the posterior pole arteries are normal. Whereas the left eye, everything is normal. The arteries, the disc, everything are normal. This is the OCT of the right eye, OCT macula, which was normal. This is the OCTA of the right eye, which also is normal. The posterior pole is normally perfused. So we have done FFA to find out the perfusion. How is this? In the right eye, we could see only the posterior pole is perfused. From the mid periphery, it is complete non-perfusion of the arterioles. And in late phases, we can see some fern-like pattern in the posterior pole as well. Whereas in left, this is the periphery showing non-perfusion of the arterioles. In the left eye, the FFA was normal. There was normal perfusion, no leakage, everything was normal. This is the HFA, this is the ELISAR fields that has been done elsewhere, so we have use that itself. So the right eye was showing a superior arcuate defect. It is a reliable field. Left eye was high false negative errors was slightly high, but still in the reliable range. And there was some peripheral depression and some nasal depression, but otherwise looking normal. Her BP was normal, her pulse was equal, and pathology test was negative. So we were looking for differential diagnosis, what could be the reason. Two things we have kept in mind. One is occlusive retinal vasculitis, and second is the occlusive vascular disease. We were more going to the diagnosis of occlusive retinal vasculitis because there was again the hypertensive component where the pressure was high. So the differential diagnosis we have kept in mind could be because of the systemic vasculitis like SLE or PAN, or because of the viral etiology like HSV or CMV, or systemic diseases like Behçet's or multiple sclerosis, or very rarely primary ocular syndromes. And second diagnosis we have kept in mind is an occlusive vascular disease, which in secondary thing caused the glaucoma. So complete systemic workup was done. Her CBC was normal, ESR was 50, CRP was 2.1, RBS was normal, peripheral smear was normal cytic, normochromic. The torch panel was checked. In that IgG CMV was positive and IgM herpes was positive. Herpes simplex, anti-treponemal antibodies were negative, HIV negative, HBsAg negative, ANA was negative, ACE, C ANCA, P ANCA, homocysteine, protein CS, everything was normal. HLA B51, 52 was also negative. We have done carotid and vertebral Doppler to rule out for any occlusive disease. But that was also normal. MRI brain with contrast was done to rule out any multiple sclerosis. That was also normal. So the IOP continued to remain in the range of 40 in spite of maximum AGM, including oral acetazolamide. We gave 250 mg QID. Still the pressure remained 35 to 40. A trial of topical steroids was given for a week. With that, she was actually steroid responsive and the pressure went up to 52. Because the IgM HSV and IgG CMV was positive, we thought we'll give a trial of antivirals. Valsiclovir of 1 gram TID was given for 2 weeks, but there was no response. The IOB continued to remain high. So we had to post her for immediate trabeculectomy with mitomycin C. And post that at 3 months follow-up, she's doing very well. Her BCVA is 6/6 parts and N6. Her IOP remained at 9 mmHg without any AGM. Yeah, actually there was a disc reversal ratio from 0.7, it became 0.4. Unfortunately, I don't have the photo as well. So this was my case presentation. This was a very interesting case where we've investigated her extensively, but we couldn't find out a probable cause, and a very unique presentation. So yeah, that's it. Hello. Hello. Can you hear me, ma'am? Hello.
Yes, madam.
Yeah, sir. Yes, I'm done with my presentations. Any questions?
Any evidence of past planitis in this patient?
No, sir. No, sir. No. The IVF was completely quiet. She never gave any history of any floaters or anything. Pars plana was normal. She had only the high pressures without any changes in the angle as such. No NVI, no NVA, no PS. But she has that occlusive arthritis. From the posterior pole was perfused. Only from mid periphery, it was not perfused at all.
What was the cause for sclerosed arterioles?
That's what we have investigated. Only we couldn't get anything. SLE and all that we have investigated. Systemic vasculitis we have investigated. Systemic diseases we have investigated. Everything was normal.
Maybe it was something congenital, and it must have occurred at that point of time. And then it resulted in maybe there were some microscopic angle changes.
Yes,
must be responsible.
Yeah, that's what we thought, must be congenital something. But she was asymptomatic till now itself only. She had suddenly raised pressures. Maybe it was like two things which have presented together as well.
But reversal of CDR is almost.
Yeah, exactly. I don't have the picture,
Unheard of.
unfortunately. Yeah, it was 0.75 CDR almost right now. Here you can see the second next, maybe I'll be able to share next time. I couldn't this time. It was only 0.4 CDR after that. And even post-trap, she behaved very differently. From the day one, her pressure was settled down at 8 and it was not going up. It's like settled there, but no CDs, AC, well formed, everything from day 1 to day 3 months, her pressure is exactly the same. It settled down at 9 with a nice cystic bleb. There were hardly any variations in the pressure as well.
Okay. Something unusual, right?
Yeah, very unusual. Yeah. That's what I wanted to discuss this more than anything else, to know, ask what else we could do in this case to know what is the cause for it. And it's unilateral only in the right eye, left eye, everything was normal.
Two different entities probably.
Yeah, two different entities must have presented together. But even if we take as a viral trabeculitis might be the cause for high pressures, but it should respond to steroids or antivirals. Nothing was, she was completely unresponsive. Her pressure exactly remained at the same thing. It didn't come down at all. It remained at 35 with all AGM, osteozolamide, everything.
Sometimes in viral inflammation, you do have a intractable glaucoma.
Intractable glaucoma, yes,
yeah,
yeah.
This
kind of, yeah.
To save the vision, probably we need to.
Yes, that's why we had intervened. We didn't wait anymore because she was unresponsive. Within a week, we have intervened and done the trap, and she's doing well right now.
Patient is lucky to have it in only one eye.
Yeah. And this association of occlusive arthritis, we didn't see in a viral this thing without any other changes in the posterior segment.
Yeah, perhaps that seems to be a very old this thing.
Yes, must have occurred some back. Yeah.
All right then.
Yeah.
Nice.
Thank you, ma'am. Thank you.
Can we go on to the next case, 1216? Next presentation.
Yeah,
it's visible. Go to slide share mode and start your presentation.
Good morning, everyone in the panel. Today I'll be presenting a free paper regarding a rare presentation of Sturge-Weber syndrome, a case report. Coming to the introduction, Sturge-Weber syndrome, it affects about 1 in every 50,000 newborns. No notable differences in incidence between the male and females are seen. No inheritance pattern, though the rare inheritance pattern has been seen, which is sporadic. Susceptibility and evidence of malignant changes are not seen. The diagnosis is obvious when basic clinical presentation of Sturge-Weber syndrome, such as unilateral facial port vein stain along the first branch of trigeminal nerve associated with hemiatrophy, progressive seizures, contralateral hemiparesis, mental deficits, hemianopia, and ipsilateral glaucoma are present. The clinical manifestations can present in 4 types: brain and facial angiomas with or without glaucoma, port vein stain without brain involvement with or without glaucoma, isolated brain angioma, usually without glaucoma, type 1, which is
slide is not moving, ma'am.
Ma'am?
Your slide is not moving.
The clinical manifestations can present in 4 types: brain and facial angiomas with or without glaucoma, port vein stain without brain involvement with or without glaucoma, isolated brain angioma, usually without glaucoma, type 1 associated with systemic manifestations like tuberous sclerosis. Approximately half of Sturge-Weber syndrome develop pathological ocular alterations, including eyelids, anterior chamber, cornea, choroid, retina, frequently ipsilateral to the port vein stain. Glaucoma is approximately to be seen 30 to 70%, which is unilateral and commonly open angle glaucoma with progressive visual field loss, and is linked to the presence of an ipsilateral port vein stain, which most commonly affects both the eyelids in 72% of the cases and only upper eyelid in 21% of the cases. Coming to my case report, a 25-year-old male with congenital port vein stain on the left side of his face presented with complaints of sudden complete loss of vision in his left eye since 15 days. Are the slides moving, ma'am?
No.
Shall I present it this way, ma'am?
Continue your presentation because otherwise we lose time. Either you can go manually to that slide or you
yeah, now it's fine right now. I'll not come out of the slideshow and then do it now. Coming to my case report, a 25-year-old male with congenital port vein stain on left side of the face presented with complaints of sudden complete loss of vision in his left eye since 15 days. Past history of having progressive poor vision in his left eye was given from his childhood. Coming to the ocular examination of the patient, visual acuity in the right eye was 6 parts, whereas in the left eye was perception of light. Near vision was N6 in the right eye, was less than N36 in the left eye. Extraocular movements were normal in both eyes. Intraocular pressures were normal in right eye, whereas it was 60 mm Hg in the left eye. Automated refractometry showed higher myopic refractive error in the left eye, that is minus 19.50 spherical with minus 2 cylindrical at 110 axis. Axial length was recorded as 22.15 in the right eye and 30.76 mm in the left eye. Coming to anterior segment examination, right eye, lids, conjunctiva, cornea, and anterior segment, anterior chamber, pupil, lens were normal. Left eye patient showed mild ptosis with telangiectatic vessels in the upper and lower eyelids, telangiectatic vessels in the conjunctiva and epicleral region bilaterally, and cornea was clear, iris was normal, anterior chamber was normal, pupils were 2 mm, and there was grade 2 RAPD, lens was clear. That's the image showing the anterior segment picture of the left eye and the right eye. Coming to the fundus examination, right eye, disc and macula were within normal limit. Left eye showed high myopic disc, which had glaucomatic optic atrophic changes and splash to matter appearance of the macula due to the choroidal hemangiomas and chorioretinal patches. Investigations, gonioscopy was done, which showed open angle in both the eyes, grade 4 Schaeffer's classification. MR angio of brain was done to rule out any other brain manifestations and syndromal associations, and it was normal. Our patient was advised to start on anti-glaucoma medications to decrease the pressures in the left eye and was advised to undergo glaucoma shunt procedures. Patient was started on lubricant drops and was advised to have regular follow-up for monitoring of the pressure, and retina opinion was also taken regularly. Coming to conclusion, glaucoma caused by Sturge-Weber syndrome is a difficult condition to treat because of its early onset and poor response to normal medical treatment due to complex multifactorial reasons for raised intraocular pressure. This patient was not under any medications and had profound visual loss due to absolute glaucoma, which was setting. In order to avoid visual loss, surgery is frequently essential to achieve long-term control of the intraocular pressure. These are the references which were taken. Thank you, ma'am.
So, what according to you was most unusual about this case?
Ma'am, Sturge-Weber syndrome presented in Sturge-Weber syndrome presented in this patient didn't involve any neurological symptoms or deficits, ma'am. Even MR angio was normal, and the patient was normal, and he's been working as well, ma'am.
So the lack of neurological involvement.
Complete no involvement of CNS, ma'am.
Anything peculiar about the involvement of the eye?
Here in the eye, usually it presents with few, either with the ocular anterior segment involvement of epicleritis and everything. Epicleritis involvement.
In your case, yeah, what was most unusual about the eye in your case, the one that you presented?
Ma'am, the pressure was extremely high, and it seemed to be high due to the glaucomatous changes in the eye, which was due to the raised intraocular pressure because of epicleral venous pressures, ma'am.
Okay. Any questions, or should we go to the next presentation?
Next.
Thank you.
Next presentation. Okay. So, 833, number 833, please share your slide. Are you there?
Am I audible, ma'am?
Yeah, you're audible. Please share your presentation. Yeah, it's visible. You can go to slideshow. Yeah, and start.
Good morning, all. I'll be presenting my paper on comparison of ocular perfusion pressure in normal and migraine patients. Introduction. Glaucoma is a disease of progressive optic neuropathy with characteristic appearance of visual field, optic disc and visual field loss that are usually associated with higher IOPs. However, in normal tension glaucoma, the damage can occur even without the raise in the IOP. certain conditions such as migraine, Raynaud's phenomena, nocturnal systemic hypotension are more commonly associated with normal tension glaucoma than with primary open angle glaucoma. This suggests that there is some vascular dysregulation underlying all these conditions, which causes ischemia to the optic nerve end. So in our study, we wanted to investigate the role of ocular perfusion pressure in migraine patients to find if there is a risk of glaucoma in migraine patients due to the low baseline ocular perfusion pressure. The ocular perfusion pressure in patients with migraine, and that compare it with that of hello, am I audible?
Yeah, you are audible.
Yeah, so the methodology, it was a hospital-based cross-sectional study done over a period of 1 year with 94 controls and 94 cases. The blood pressure was measured in sitting position in the right arm using a manual sphygmomanometer, that is the Welch-Shannon Ernoid, with an adult cup. And the IOP was measured using a Goldman applanation tonometer and corrected with central corneal thickness values by pachymetry. And this was measured during the daytime, that is the OPD hours between 10 to 12 a.m. Right eye IOP was considered for calculation purpose. The inclusion criteria included age group of 18 to 40 years, both males and females, and migraine patients who were diagnosed irrespective of whether they were on or off prophylaxis, and also newly diagnosed migraine patients who are not yet on any treatment are also included. The exclusion criteria was previously suspected glaucoma cases or diagnosed glaucoma cases, hypertensive patients, any other ocular or systemic diseases, previous ocular surgeries, pregnant women, substance abuse, and other systemic medications such as antihypertensive medications, anti-diabetic medications, or any of those medications is excluded. So the mean arterial pressure was calculated as 1/3 of systolic blood pressure plus 2/3 of diastolic pressure. From this, we calculated the ocular perfusion pressure, which was 2/3 of the mean arterial pressure minus the intraocular pressure. The ocular perfusion pressure of migraine patients was then compared to that of normal age-matched controls. Descriptive statistics was used to analyze the data. So in results, we had in the cases, we had 31 males, which contributed to 33% of the cases, and 63 females, which contributed to 67%. And in controls, it was 30 males and 64 females. As by here in the results, we can see that there was no much significance seen between the two groups. The intraocular pressure in both the groups, cases and controls, was about the same. In cases, it was 13.27 mean, and in controls, it was 12.5. The ocular perfusion pressure in the cases was 47.69 plus or minus 2.43 millimeters of mercury, whereas in the controls, it was 46.08 plus or minus 2.46 millimeters of mercury. The discussion. So the common pathology behind migraine, systemic, and glaucoma is vascular dysregulation. Optic nerve is vulnerable to ischemia when the ocular perfusion pressure is reduced. So in such situations, the optic nerve is susceptible to an even more normal IOP, as in NTGs. So however, the ischemia does not result from simple inadequacy of blood flow, and the damage occurs with an episode of transient ischemia and also with reperfusion injury. So in our study, migraine patients had almost the same ocular perfusion pressure as that of normal controls. What we found was at least that it was not lower than that of the normal controls. It was possible that fluctuations can occur in ocular perfusion pressure before, during, or after the migraine attack. So we had 4 patients present to us with an attack of migraine, and it was seen that the ocular perfusion pressure was reduced as the diastolic BP was reduced. IOP and systolic BP remained normal. However, to continue the study, we need continuous monitoring of ocular pressure perfusion for longer periods and in a sample of a larger size. To conclude, there was no statistical significance found between the ocular perfusion pressure of migraine patients and that of normal controls. These are my references. Thank you.
Najib, you included patients, okay, irrespective of treatment, right?
Yes, ma'am.
Who are receiving treatment for migraine. Is that correct?
Yes, ma'am.
And commonly used medication for migraine do cause vascular changes, right?
Yes, ma'am.
So that not have affected, and many people are on treatment for migraine.
Yes, ma'am.
Maybe
What we
that
found was
have
there were
affected.
cases who were diagnosed as migraine, but were just on not on treatment, ma'am. A few of them had started treatment and then left it as the cases had, the episodes of headache had reduced. We had
Perhaps
around
analysis of this, whether on treatment, off treatment might have given you a little more information.
Okay.
Anyway, yeah, that's it from me. Anybody else has questions, or we move to the next presentation?
Thank you.
Yeah, thank you. We'll move on to the next presentation.
Hello, this is Shaista here. My number is 1430, ma'am. Can I present?
1430. When was yours?
Sorry, ma'am.
It's not in the list.
Yeah, it's not in the list. Yeah.
1430, ma'am. It's the glaucoma.
No, it's not in our list.
Okay, I'll get back to you, ma'am.
Can you just
I'll ask
confirm it?
organizer.
Yeah. Meanwhile, I think 1333 can start. 1333.
Ma'am,
Yeah.
am I audible?
Yeah, then please start.
Good morning. Ma'am, is the screen visible, ma'am?
Yes, please go ahead.
Good morning. The study, what we have done is study on of demography and clinical spectrum of pseudoexfoliation syndrome. Introduction: pseudoexfoliation syndrome is a systemic disorder that is the currently most common identified specific entity leading to development of secondary glaucoma. It is more aggressive with a high mean progression rate leading to full field blindness within 10 years. The main objective of the study was to assess the demographic aspects, clinical spectrum of pseudoexfoliation syndrome. The methodology was used. It was an observational study of 100 patients. The patients included in inclusion criteria were patients with pseudoexfoliation syndrome attending our hospital. The exclusion criteria included any patients who had previous intraocular surgeries, history of trauma or uveitis, and corneal opacities obscuring the anterior segment structures, any ocular pathologies that could have led to secondary glaucoma, or patients who are not giving consent for the study. The study period was in between October 20 to July 21, that is for a period of 10 months. The patients underwent vision check, which is unaided and best corrected visual acuity.
Exit, yeah.
Slit lamp examination, which included anterior segment examination, which included conjunctiva, which to look for circumcorneal congestion, the cornea to look for edema, pseudoexfoliation material on endothelium and pigmentation, the anterior chamber to look for depth, flare, and pseudoexfoliation materials, iris for transillumination defects and pattern, pupil for size of pupil, the pseudoexfoliation material in pupillary margin and reaction to light, lens for pseudoexfoliation material in the anterior surface of the lens, and cataract association with pseudoexfoliation syndrome. Intraocular pressure measurement was done by using Goldman's applanation tonometer. Fundus examination was done using indirect ophthalmoscopy with 20 diopter lens and slit lamp biomicroscopy using 90 diopter lens. Here are the results. First, coming to laterality, the most commonly the pseudoexfoliation syndrome appeared to be bilateral, which is around 60% of the patients, compared to 40% who had unilateral association. In those unilateral patients, almost equal predisponents were there for both the eyes. The right eye was slightly more compared to the left eye with 51%. Coming to gender, the males had slightly more predisponents for pseudoexfoliation syndrome with 55% compared to female who had 45% of incidence. The most common age group in both unilateral and bilateral cases was around 61 to 70 years. The youngest patient included in our study was around with pseudoexfoliation was around 50 years old, and the oldest patient was around 94 years old. Coming to the location of pseudoexfoliation material, 90% of the patients who presented had iris degranulation, along with 75% of those had the pseudoexfoliation material on the pupil. Out of these 75%, around 60% of the patients had non-dilating pupil. Around 7% of these patients had pigments on the anterior lens capsule, and the remaining had pigments on the corneal endothelium. The patients who had pigments on anterior lens capsule also exhibited iris transillumination defects. There were around 8 people who had pseudoexfoliation material on the anterior lens capsule. Coming to intraocular pressure, 85 of 100 patients had normal intraocular pressure. 15 patients had high intraocular pressure, in which 8 showed glaucomatous cupping. The remaining had normal disc. The most common type of cataract associated was of nuclear sclerosis of grade NS4 to NS5. And around 10% of these patients also exhibited phacodonesis at presentation. Coming to conclusion, bilateral pseudoexfoliation is more common as this could be because unilateral cases invariably may become bilateral at a later date. The age group of presentation, most as pseudoexfoliation is disease of age. Here in our study, we found that unilateral and bilateral cases were more common in the age group 61 to 70 years. 55% of pseudoexfoliative patients were males. This could be due to the fact that under the non-genetic cause of pseudoexfoliation, ultraviolet light is a possible etiology. In the Indian setup, because more males are more involved in outdoor activities, there is a definite male predisponence compared to females. Most of the patients had degranulation of the pupillary rough, and the main pseudoexfoliation material was found on the pupil. The most type of cataract associated was nuclear sclerosis of grade NS4 to NS5. The study concluded with the need of earlier diagnosis and various complications involved in pseudoexfoliation syndrome, and possible complications which can occur in cataract surgery in a patient of pseudoexfoliation syndrome include elevated IOP, glaucoma, poor mydriasis due to non-dilating pupil, zonular weakness which can lead to phacodonesis, and high rate of vitreous loss. So pseudoexfoliation syndrome should be routinely screened and before taking a patient for any operative procedures. Thank you.
Did you do any gonioscopy?
No, ma'am.
I mean, you're evaluating a glaucoma case. You have spoken everything of anterior segment in detail, but you're not mentioned about any reason you did not include gonioscopy. Any reason that you didn't include the gonioscopy?
No.
Are they always open angle, or you could have angle closure variety also in pseudoexfoliation? Are you aware in a small percentage of cases?
Yes, ma'am.
One suggestion is always include gonioscopy also.
Okay.
Since you are speaking everything about pseudoexfoliation, I think it's important to include.
Okay.
All right. Yeah.
Yes.
Okay. That's it from me. Does anybody else have any questions, or do we go to the next presenter? Next.
Okay, we'll go to the next.
Yeah, 1349.
Yes, ma'am.
Yeah, please go ahead, share your screen and start your presentation.
Good morning, everyone. My topic of presentation is Association of Platelet Aggregation Parameters and Primary Open Angle Glaucoma. Glaucoma is a progressive optic neuropathy characterized by structural changes in optic disc and retinal nerve as retinal nerve fiber layer changes and functional changes in the form of visual field defects. The pathogenesis of glaucoma is multifactorial, and IOP is the only known modifiable risk factor. There are two theories for the occurrence of these changes. One is the mechanical theory, which states that the stretching of laminar beams, which is due to raised IOP and also causes damage to the retinal ganglion cell axons. Another one is a vascular theory, which states that the glaucomatous optic atrophy is a consequence of insufficient blood supply. Altered platelet aggregation in glaucoma has an inverse relationship with the blood flow in the small branches of the short ciliary artery supplying the optic disc, which is compromising the blood supply. Platelets contribute in blood coagulation and microcirculation, and its activation and endothelial interactions play a major role in the vascular theory. Platelet parameters like platelet count, mean platelet volume are indicators of production rate and size of the platelets. Platelet distribution width and platelet grit indicate the variation in size, and it represents the fraction of platelets in the blood respectively. Platelet activation leads to change in the shape, making it more spherical, and hence the platelet distribution width, which is a marker of variation in size, is a specific marker of its activation. Larger platelets are more adhesive and are likely to aggregate than small ones, suggesting that mean platelet volume is also an indicator for its activation. The aim and objective of this study was to compare the association between platelet aggregation parameters in patients with and without primary open-angle glaucoma. And also to correlate this platelet aggregation parameters with the severity of glaucoma. Methodology is, it's a cross-sectional observational study which included cases of patients who are aged in 40 to 70 years and patients who are detected to have glaucoma based on IOP, which is more than 21 mmHg, or vertical cup disc ratio of above 0.7, or inter-eye symmetry of 0.2 with or without notching, and neuroretinal rim thinning or retinal nerve fiber layer defect. Visual field defect that corresponds to the presence of at least 3 contiguous non-edge test points within the same hemifield on the corrected probability plot at p less than 0.05 with at least 1 point less than 0.01, excluding points directly above and below the blind spot. Controls included patients of same age, that is 40 to 70 years, and patients with IOP less than 21 mmHg with normal optic disc and no clinical evidence of glaucoma. Exclusion criteria included patients who had any abnormal coagulation function or any hematological disorders, patients with severe cardiovascular, renal, or hepatic disorders, or patients on any antiplatelet drugs or any anticoagulant medication, patients with acute infections or any autoimmune diseases, cancers, or even thyroid dysfunction. A total of 106 participants were recruited, 53 cases with primary open-angle glaucoma and 53 age-matched controls. All the enrolled participants underwent a comprehensive ophthalmological examination by a glaucoma specialist, and the cases were grouped as mild, moderate, and severe primary open-angle glaucoma based on their clinical optic nerve head findings and mean deviation value of the visual fields. In bilateral cases, the eye with the worst mean deviation was selected. 1.5 ml of venous blood sample was collected and analysis for complete blood count was done to study the platelet aggregation parameters, that is platelet count, platelet distribution width, platelet grit, and mean platelet volume. The results of the study were, the mean age of the patients was 59.9 in cases and 56.6 in controls. In cases, there were 34 males and 19 females, and in controls, there were 27 males and 26 females. In the primary open-angle glaucoma group, the platelet distribution width was in the range of 16.29 plus or minus 1, and mean platelet volume was in the range of 8.48 plus or minus 0.3, and these are significantly higher than those in the control group, which is of platelet distribution width 15.85 and mean platelet volume of 8.7. In the primary open-angle glaucoma, the platelet counts were lower when compared to controls, but it was not statistically significant. On the basis of clinical optic nerve head findings and mean deviation of the fields, the subjects were divided as There were 21 cases in mild primary open-angle glaucoma, 10 in moderate, and 22 in severe primary open-angle glaucoma. The platelet count and platelet grit were lowest in the moderate group, and mean platelet volume and platelet distribution width was highest in the moderate group, but it was not found to be statistically significant. There was no statistical correlation with the increasing platelet parameters with the increasing severity of glaucoma. Discussion. The vascular theory of pathogenesis of glaucoma considers insufficient blood supply due to reduced ocular flow to be the cause for ischemia and subsequent retinal ganglion cell death leading to glaucomatous optic neuropathy. In low tension glaucoma, we know that hypercoagulability is considered as a pathogenesis of the disease, and platelets contribute in blood coagulation and microcirculation. Therefore, its activation helps in identifying its role in the disease process. In our study, patients with POAG had significantly higher platelet distribution width and mean platelet volume values when compared with age-matched controls. The platelet counts were lower, though not statistically significant. This was compared with a study conducted by Vaimi et al., where they included 420 subjects. The platelet aggregation parameters and severity of glaucoma did not show any linear correlation with each other in our study, which might be due to the low sample size. Increased platelet distribution width and mean platelet volume implies that platelets are larger and are more active. They tend to have a higher prothrombotic potential and aggregate more rapidly. This could lead to reduced ocular blood flow. There are a few studies conducted which show similar results, like Hyong et al. Found association between spontaneous platelet aggregation and primary open angle glaucoma. Matsumoto et al. Showed increased platelet aggregation in normotension glaucoma and primary open angle glaucoma. Conclusion of the study was platelet distribution width and mean platelet volumes were found to be higher, implying increased aggregation parameters in POAG patients. This suggests that the possibility of platelet activation being an important factor in the pathogenesis of vascular theory of development of optic nerve head damage in POAG. Further studies with higher sample sizes should be considered, which could help in throwing light on the use of antiplatelet drugs like aspirin in delaying the development or progression of glaucoma. These are my references. Thank you.
You said this is an observational study, right? So
Yes.
observational study means this whatever blood is being sent for analysis of these platelet related factors, they are not done routinely. They have probably done for the purpose of this study, isn't it?
Yes, ma'am.
Yeah, because if it is normally done and you've just recorded the values of whatever tests are done normally, perhaps it becomes an observational study. You're, I don't know, you're subjecting them to a test, isn't it?
Yeah, yes, ma'am. Like routinely, we had sent for a complete blood count, but actually, we spoke to the lab people and they said that this can be done. Then
How much is it? Is it very expensive to get this platelet related test that you have mentioned?
It's around. It will cost around 130 to 140 per patient, ma'am, in our setting.
Okay, all right. And so the implication that you're trying to, are there any Indian studies done on this same lines?
Ma'am, Indian studies, they have not exactly considered all the parameters, ma'am. There are some studies which show that thrombin might be also an important factor. But here, main study, what we considered was done in China.
Aggregation factors.
No, ma'am. No, ma'am. Or maybe it has not been published yet, ma'am, but there was no published study which could have been seen.
All right. Yeah. Anybody has any questions for her?
Go on.
1349. So next one is 1425.
Yes, ma'am.
1425?
Yes, ma'am.
Yeah, please start sharing your presentation.
Okay.
Your presentation is still seen. Can you end your presentation? 1425?
Yes, ma'am.
Yeah, we're not able to see your presentation. Okay, we're able to see it.
Yeah. Good morning, everyone. My paper is on a comparative study evaluating the outcome of two techniques of releasable sutures used in trabeculectomy. Glaucoma is a group of acute and chronic progressive multifactorial optic neuropathies in which the IOP, among other contributing factors, are responsible for a characteristic acquired loss of retinal ganglion cells, cell axons, leading to optic atrophy with demonstrable visual field effects. IOP is a major risk factor for glaucoma, and therefore lowering IOP remains the mainstay for glaucoma treatment, and trabeculectomy has been the gold standard. To prevent the complications of excessive overfiltration associated with trabeculectomy, such as hypotony and maculopathy, and hypotonic maculopathy, releasable sutures techniques were adopted. And here there is manipulation of the suture tension in the early stages following trabeculectomy, which decreases the complication rates and improves the success rates, hence slowing the progression of glaucoma.
The releasable sutures allows the surgeon to close the scleral flap loose enough to permit aqueous humor outflow, but also tight enough to prevent post-op hypotony, thereby reducing the incidence of early post-op complications. Filtration can be increased in small increments and thus finally stimulating a full thickness filtration procedure. Methodology. This was a randomized open label study done over a period of 1 year. 50 patients were arranged in 2 groups of 25 each, and they were randomized in a ratio of 1:1 to undergo TRAB using releasable sutures, either through the Cohen and Osher technique or the Rootman's technique. And the inclusion criteria were patients who were willing to give a written informed consent, patients with primary open angle glaucoma, that is the IOP greater than 21 after maximal medical treatment, who had open angles on gonioscopy, who had glaucomatous optic atrophy, visual field defects compatible with the glaucomatous optic atrophy, and patients with secondary open angle glaucoma. Exclusion criteria, those patients not willing to give consent, primary and secondary angle closure, congenital glaucoma, uveitic glaucoma, and coexisting, those having coexisting retinal pathologies, and wherein there was history of trauma to the eyes. Results. In the Cohen, we saw that in the Cohen and Osher group, males were about 64% and females were 36%. And in the Rittman group, males were 80% and females were 20%. In the Cohen and Osher group, about 24% had to undergo suture removal. And in the Rittman group, about 36% had to undergo suture removal. In the Cohen and Osher group, the second week post-op, second week suture mean IOP was about 23.67, and post-suture removal, it came down to about 11.67 millimeters of mercury, wherein there was 50% reduction of IOP from the second week IOP after 6 months. In the Rootman group, the second week IOP, post-op second week IOP was 23.56 millimeters of mercury. Post-suture removal, 6 months, it was at 6 months, post-suture removal after 6 months, it was about 11.78 millimeters of mercury. They also showed about 50% reduction of IOP from the baseline. So discussion, there was a similar study done by Duman et al. In 2015, wherein it was a retrospective study, and they reviewed the charts of patients who had underwent primary trabeculectomy by 3 surgeons using 3 different techniques of releasable sutures. 90 eyes were included, and they compared the outcome of the 3 techniques. They observed that the mean reduction in IOP after surgery was over 30% in all the groups. And all the 3 groups, it was 30%, and the complications were also similar in all the 3 groups. Therefore, they concluded that all surgical techniques can be used for scleral flap closure, had the same mechanism of action, were effective, safe, and had similar outcomes. There was one more study which was conducted by Hosni and et al., which it was a prospective randomized study in 2009 to demonstrate a technique for releasable scleral flap suture placed to reduce the post-TRAB complications. 15 eyes were included. They concluded that the releasable sutures provide better control of filtration in the post-op period, reducing the incidence of complications. In addition to that, it is also an easier, the technique of removing the sutures was easy, and there was which can be done on the slit lamp, and also it was associated with less complications. So conclusion, we conclude that both the techniques are effective in controlling the post-op IOP. In both techniques, sutures were relieved in among the study subjects, and IOP reduction was similar. Hence, both the techniques can be used to reduce the used to close the scleral flap sutures in patients undergoing primary trabeculectomy. Thank you.
Dr. Shaista, you were the one who had a doubt, right? That time, was
Yes,
that sorted out?
Yes, ma'am.
You had the
Yes,
wrong
ma'am.
number. This is your presentation.
Yes, ma'am.
Okay, fine. Does anybody else have any questions for her?
No.
I just wanted to see your objective. Can you just show me the objective slide?
Ma'am.
Can you just tell me otherwise what was your objective?
Ma'am, our
In
objective...
results, you put others' results.
Sorry, ma'am. Objective was to compare the 2 techniques, ma'am, and to know the IOP reduction, how was it in both the techniques, and whether it was the same or not, ma'am.
Okay, and results should ideally be your results. You have compared others' results.
Ma'am, these are my results, ma'am.
This one?
Yes,
Cohen and
ma'am.
Osha. Okay. Fine.
Yes, ma'am. These are mine. We did
You
two
have
techniques.
named your
ma'am.
groups
Cohen and-
like this.
Yeah,
You have
Cohen
named
and
your groups
Osha.
like
Yeah, ma'am. Cohen and Osha and Rutman group, ma'am.
Okay. Yeah, this I got a little confused. All right.
These are my results. ma'am. This was the discussion. ma'am.
Okay, fine. Yeah. Thank you.
Thank you.
Next presenter.
1010.
Yeah, 1010.
Meanwhile, Dr. Sheetal, can you tell me who was the first person presented?
1520 was not yet presented, ma'am. Some issue was there.
Yes, ma'am.
1520 is not presented and 1198 has not presented. Okay. So we'll finish 1010, then we'll go back to them.
And 1054 is done?
1054 is done, ma'am. That was the first presentation, I think.
Okay.
Yeah, 1054 was the first presentation that happened. Although it was somewhere in between, I think that person has presented first.
Okay. Thank you.
Yeah. So 1010, are you ready? Yeah, please go ahead. Dr. Anita, you're not audible. We can't hear.
Is it Dr. Swati? 1010.
Yeah, Dr. Swati, correct. Sonwalkar. We can't hear you. Maybe you can end the presentation. We will ask Dr. Abdul 1520 or 1198 to present.
1520.
Please sort out your connection.
Yeah. If you're ready, you start.
Yes, ma'am. Hello, am I audible, ma'am?
Yes, please go ahead.
So we have done a correlative study of central corneal thickness and intraocular pressure with optic disc changes and visual field defects in primary open-angle glaucoma. So glaucoma is a optic neuropathy characterized by a typical appearance of optic nerve head and characteristic visual field loss. It is a progressive condition and is the most common cause of irreversible blindness worldwide. So primary open-angle glaucoma is a type of glaucoma defined as open and normal appearing anterior chamber angle with raised intraocular pressure. Nearly 90% of the glaucoma is undetected, and in third leading cause of blindness accounts 5.8% total blindness in India. In most patients, the glaucoma clinically recognizable disc changes precedes the detectable field loss. Around 25 to 35% loss of the retinal ganglion cell may be there. Then the reproducible early visual field defects are detected. So optic nerve head cupping is also used to predict the type of field loss. Extensive and focal absence of neural rim tissue, especially inferior and superior pole, is the most reliable indicator for visual field disturbances. Central corneal thickness could be correlated with the severity of the disease. In decreased CCT was associated with lower rim areas and greater cup to disc area in subjects with primary open-angle glaucoma. Intraocular pressures was positively related with the central corneal thickness and may influence the division between the normal and the increased intraocular pressure at a simple cutoff of 21 mm Hg. So purpose was to study and correlate the central corneal thickness, intraocular pressure and disc changes and visual field defects in POAG that can help in early detection and timely management of the primary open-angle glaucoma and to prevent advanced damage and vision loss. So study material, it was a prospective and observation study that was between January 2021 to October. So 60 samples were taken, including the exclusion criteria. So diagnosed patients with primary open-angle glaucoma was taken, and age between 30 to 80. And the patients at the time of presentation 21 mmHg or higher. The gonoscopic angle examination showed the open angles. So exclusion criteria was ocular hypertension patient, normal Texan glaucomas, then secondary glaucomas, post-RAP patients, and patient who had glaucoma drainage devices, corneal disorders, post-refractive surgery patients, and post-segment pathologists. So results were, so in our study, the average age for the patients who were presenting with the POAG was from 51 to 60 years. They were the maximum, then the 61 to 70 with the second number. So the mean age was around 51 to 60 years. So in gender predisposition, in that male were at the higher side, 60% patients were male and 40% were female. So in the visual acuity, we have divided the patients into 3 groups: vision more than 6/12, and between 6/12 to 660 and less than 660. So in that, majority of the patients were between 612 and 660. Then we have divided the patients according to the intraocular pressure before correcting the CCT and after correcting of the CCT. So in that, majority were around 57% were between the intraocular pressure 21 to 30, and next group was between 31 to 40 mmHg, and few patients presented with more than 40 mmHg. So according to the CDR ratio, vertical and horizontal were measured. So in that, 38% patients were having a coverage ratio of 0.7 to 0.6 to 0.7, then 0.4 to 0.5 contributed to the second factor, and 0.8 to 0.9 cupping was there in around 30%, and these were the people who were having a low CCT. So the different visual field defects what we have encountered during this procedure was, so most commonly patient presented with inferior arcuate and superior arcuate scotoma that will moderate disc changes, and in advanced disc changes by arcuate scotoma was seen, and around 10% were nasal steps, and tubular field vision loss was there only 1%, where there was advanced cupping, 0.9 cupping was there. So in HAP study, HAP staging, so we have divided into early, moderate, and severe, and advanced, and stage disease, and normal patients. So in that, 44% were having a moderate field defects, and 30% were early. So advanced and end-stage diseases were 4 to 5%, and 10% were normal. So in the CCT, the mean CCT which was done in males, it was 520 to 1.19 micron, and in females it was 518, and it was not clinical, means there was not a significant difference between male and female compared to CCT, whereas in the right and left eye, it is almost it was like there also 30% lower and medium was there, but there was no clinically, means not that much significantly correlated with that. So most important thing what we have seen is the patients who were having a lower CCT were having more advanced cupping, and were having more glaucomatous field damage, where the CCT was less than 510. So we have divided the patients into 3 groups: patients who are having less than 510 microns, and 510 to 30, and more than 5.
You have only 6 minutes for your presentation. Okay?
Yes, sir. Yes, ma'am. Finish, ma'am.
Yeah.
So in the discussion, what we have seen is, so 30% were having early fields, and those were having 0.4 cupping, whereas 0.6 were matched. So main thing in our discussion is the patients who are having a lower CCT are going to for a more cupping, and visual field defects are more common in sense. So Sullivan et al. A retrospective study, what they have done is they have sent the central corneal thickness where at asymmetry, the thinner corneal thickness are at a greater risk for advanced visual field loss, and vertical.
I think you already crossed your time. I think you need to hurry up. Yeah.
Yeah. So in the conclusion, I want to just tell that intraocular pressure was positively correlated with central corneal thickness. So thinner CCTs are at a greater risk of advanced visual field loss, and disc cupping is increased proportionally to the increased IOP. So optic nerve changes seen prior to the development of visual field changes. So we have to check CCT in the patients who are coming for our OPD clinic. So thinner CCT should allow the ophthalmologist to evaluate patients thoroughly for glaucoma, so that it not be misdiagnosed, and we can start the treatment appropriately. Thank you. These are my references.
Can we go to the next presenter, 1198?
Good morning, ma'am. Shall I share my
please start.
screen, hello,
and please stick to your time of 6 minutes.
Yes.
Yeah.
Oh, sure, ma'am. Yes. My slides are Good morning, everyone. So my free paper is on assessment of macular parameters in primary open-angle glaucoma using optical coherence tomography. We don't have any financial disclosures. Glaucoma is the leading cause of irreversible blindness in
Check
the
your
world.
net connection, mom.
Primary open-angle glaucoma is the most common type of glaucoma, which is characterized by progressive optic neuropathy with characteristics. Hello, ma'am. Can you hear me now?
Breaks.
Hello.
Your voice is breaking, ma, not heard.
I think there are some network issues. Your voice is breaking.
Is it audible now?
Are you there,
Glaucoma is one
Akshita?
of the leading cause of irreversible primary open-angle glaucoma is characterized by progressive optic. Yes, ma'am, I'm there, ma'am. Hello, ma'am, you can hear me now?
Yeah. Continue. Go with the methodology now.
Yes, ma'am. And the objective of our study is to assess the macular parameters using optical coherence tomography in primary open-angle glaucoma patients and correlate it with the RNFL parameters in the POAG patients. So it's a hospital-based case-controlled observational study which was conducted at the Tertiary Care Center with 65 patients with primary open-angle glaucoma and 65 age-matched controls. The inclusion criteria was the patients who gave informed consent, visual field changes suggestive of glaucoma, open angles on gonioscopy, glaucomatous optic disc changes, and clear media. Whereas we didn't include the patients who had any retinal or macular pathologies and anterior segment opacity, which would preclude the accurate field testing and hinder the OCT imaging of such patients. Coming to the results part, we had the mean age of 52 years in our study population with a standard deviation of 9 years, and the control group had the mean age of 55 years with standard deviation of 13 years. We saw that our study group had consisted more of males, which made around 53%, and females made around 46%. In our control group, 38 patients were male and 27 were female. Iop distribution, the mean Iop recorded in the POAG subjects was 21 millimeters of mercury with standard deviation of 3.26, whereas in the controls it was 13 millimeters of mercury with standard deviation of 2.83, which showed a statistical significant difference between the two groups. Central corneal thickness in the POAG group was recorded, the mean record was 539 with a mean deviation of 12.12, and the control group was 560 micron with the standard deviation of 11.10.
Is 1010 ready?
Hello, ma'am.
You're not audible, ma'am.
Ma'am, am I audible now?
Yeah, your screen is seen now. Dr. Sheetal, can we continue with 1010?
I'm sure. Please go ahead.
Ma'am, can you hear me, ma'am?
Yeah, Swati.
You're audible.
Good morning, everyone. My topic for paper presentation is clinical profile and ocular biometric parameters.
Share your screen.
My topic for paper presentation is clinical profile and ocular biometric parameters of primary angle closure disease. Primary angle closure disease is a common in Asian populations, with Indian accounting for 23.9% of world's angle closure glaucoma. Although primary angle closure accounts for only 26% of all the cases of glaucoma worldwide, more than 50% of glaucoma blindness is attributed to primary angle closure glaucoma. Previous studies on ocular biometric parameters in angle closure glaucoma have reported shallow anterior chamber depth, higher lens thickness, and shorter axial length and smaller corneal diameter. Several studies have been conducted in different parts of India to study the profile of primary angle closure disease. No study have been performed in central Karnataka, of which our institute is a part of. Hence, this cross-sectional study was undertaken to study the clinical profile and ocular biometric characteristics of patients with spectrum of primary angle closure disease at our institute. Objectives: to study the clinical profile and ocular biometric profile of primary angle closure disease. Coming to methodology, this cross-sectional hospital-based study included 60 eyes of 30 patients. All patients underwent comprehensive glaucoma evaluation and ocular biometry. The axial length, anterior chamber depth, lens thickness was measured for each eye using ultrasound biometer, and central corneal thickness was measured using ultrasound pachymetry. The measured parameters were used to calculate corrected antechamber depth, which is antechamber depth minus central corneal thickness, and the lens position, which is antechamber depth half plus half the lens thickness, and relative lens position is lens position divided by axial length into 10. Now, coming to inclusion criteria, patients aged above 40 years of either sex who have been clinically detected to have primary angle closure disease, patients willing to participate and give informed consent in the study. And exclusion criteria are patients with normal tension glaucoma, open angle glaucoma, ocular hypertension, patients with secondary angle closure glaucoma like phacomorphic, inflammatory, and neovascular glaucoma, patients who have undergone prior ocular surgery, patients with history of ocular injury, patients in whom angle structures are not visible secondary to opacities in cornea, and patients who are not willing to participate in the study. Coming to results, the mean age which was found in our study was 52.2 plus or minus 9.6 years with female preponderance, and PACS, PAC, and PACG was diagnosed in 23, 11, and 24 eyes respectively. One eye had acute angle closure crisis and one eye was pseudophakic. We found that all eyes with primary angle closure disease were hypermetropes with spherical equivalent of PACG, PACS, and PAC was 0.69 plus or minus 2.5 and plus 0.97 plus or minus 1.5 and plus 0.91 plus or minus 2.8 respectively. Then central corneal thickness in patients with PACG, PAC, and PACS was 520 micrometer and 530 and 540 respectively. And coming to axial length, which was on lower side in all the age group, but they were not statistically significant. And even corrected anterior chamber depth were towards the normal range, and they were not statistically significant between all the three groups. And even lens thickness was not found to be much greater in number, and it was not statistically significant. Coming to lens position and relative lens position, which was highly significant in our patients, where relative lens position was significantly lesser in our patients with 2.17 plus or minus 0.32 in PACG and 2.05 plus or minus 0.28 in PAC and 2.05 plus or minus 0.43 in PACS with it was not statistically significant among three groups. Coming to discussion, in our study, a significant association was found for subjects aged more than 60 years with female preponderance, which was similar to study by Shiota et al., where with maximum patients with PACD in 6th decade with female predominance. All the patients with PACD had hypermetropia, which is similar to study by R. Lowy et al., where all patients with PACG had refraction between plus 1.25 to 1 plus 2, and very few are myopic. In the present study, the mean central corneal thickness in patients with PACD was found in normal range, which was similar to study by Mohammad Reza et al. Then in our study, the mean axial length in patients with PACD was relatively on lower side in all the groups, which was similar to study by R. George et al., where they found mean axial length of PACS was 22.07 mm in PACS and PACG 21.92, and it was significantly lesser than the normal range. Hence, the shorter axial length was seen in our study and in various studies suggested an anatomical predisposition to occludable angle and angle closure glaucoma.
Yeah, please rush. Okay, it's already time. Yeah.
Okay, ma'am. Ma'am, conclusion in our study was majority of patients with PACD tend to have PACG and PACs at presentation. Patients with PACG had advanced to end-stage disease at diagnosis, emphasizing the need for improved glaucoma screening measures to ensure the early detection of PACD to reduce the blindness rate. And patients with PACD have lower axial length, anterior chamber depth, and significantly anteriorly positioned lens, which may contribute to the development of primary angle closure disease. Although the biometric parameters did not differ between the three groups, but they were lesser than the normal reported data. A prospective study which allows the progression of biometric variables may throw the light on the role of these parameters in the progression from PSCS to PAC and PSCG. Thank you, ma'am.
Anybody has any questions? Any questions? Otherwise, with the permission of the other judges,
yeah,
should we end this session?
Yes.
Is it okay with all the other judges? Shall we end the session?
Yeah, Dr. Sheetal, we'll end it.
Okay. So I thank all. Yeah, thank you all the presenters.
Hello, ma'am. Sorry to interrupt. I couldn't complete my presentation, ma'am. Can I present it now? My FP number is 1198. There were some technical glitches.
1198.
Not presented, I think. Yeah.
You haven't completed?
No, ma'am. I couldn't complete the presentation. There was some technical.
You were midway? Were you midway?
Yes, ma'am. I was midway.
Okay, you continue from where you stopped.
Yes, ma'am. Sure.
Sheetal savu. Moodalla adda anta heltaru.
Ma'am, I want to share this.
Yeah, please do so.
Why is yours coming like this?
Fast.
Email ID ಕಟ್ಟಿದ್ದ email ಗೆ ಅಟ್ಯಾಚ್ ಮಾಡಿದ್ದ
My paper was about assessment of macular parameters in primary open-angle glaucoma using optical coherence tomography. So it was a case control study where we had patients, POAG patients comparing with the contours starting with the central to the control group, which was found statistically significant. And among the inner macular parameters, all the quadrants of the inner macular parameters correlated well. Its statistical significance was seen between the POAG group and the control group. Even the outer macular thickness, we found out that there was thinning in all the quadrants compared to the control.
Sorry, Akshita, you're not audible. My voice is breaking. Some issue.
As the macular volume. Am I audible now?
You're audible, but it is breaking every now and then after the first line. Must be some internet issue there, ma.
Am I audible now?
No.
Ma'am, I'll just conclude it with my conclusion. Hello.
Yeah, put it.
Yes, ma'am. So the study which we did, we found out that the macular parameters correlated well with the which helped in the diagnosis of POAG in the patients which had optic disc changes like tilted disc, where performing capillary RNFL OCT was difficult to diagnose POAG. Ma'am?
Yeah, you finished?
ನಿಂದು ತೋರಿಸ್ತಾ ಇಲ್ಲ ನಂದು ಫಸ್ಟ್ ಯಾರು
Ma'am, basically, hello.
You're done now, Akshita?
Yes, ma'am.
Okay. I think you have severe internet issues. Yeah, but doesn't matter. We have seen some of it.
Yes.
Okay, just well presented, everybody.
Study was a case control study, ma'am. My study was a case control study where we compared POAG with the control group, and which showed that the macular parameters were when we compared, there was statistical difference which showed that the macular thickness was reduced in the POAG group compared to the control group. And there was correlation between the RNFL parameters as well as the macular parameters. Yes.
Yeah, we read your conclusion, Akshita. It's done.
Thank you, ma'am. Thank you so much.
Stop
Sorry
sharing.
for the technical glitches, ma'am.
Yeah, that's all right. You can end it. Yeah. So one suggestion to most of the speakers, you were supposed to have only 6-minute time, and many of you have crossed that. So remember, if you have crossed your time limit, you lose points on it. Okay. So you must keep the time factor in mind. Plan your slides accordingly. And I thank all other judges also for their input. So I think we'll end the session.
Yeah,
thank you. Thank you, madam. Thanks for other judges.
Yes, ma'am. Shall we end?
Yeah.
Okay,
Yeah.
Okay, ma'am.
Thank you.
Thank
Thank you so much.
Okay, thank you, Cosmo.
Thank you.